Good morning to everyone. We will get started in just a minute once everyone has an opportunity to join.
Caitlin, I'm getting a message that the host has stopped my video.
Yes, if you could turn your video on again when you give your opening remarks, Deirdre.
Okay, thank you.
Thank you.
We'll start in just a moment. Okay, good morning. I'm so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and it's my great pleasure to co-chair the National Academies Forum on Mental Health and Substance Use Disorders together with Howard Goldman. This webinar continues and extends a conversation we began with our June 3rd forum webinar. As I did in June, I want to take a brief moment to acknowledge the dual public health crises that we are confronting, both with profound implications for mental health and well-being. The COVID pandemic and its rapid and devastating social and economic consequences is taking an enormous toll on our mental health and, by recent accounts, deepening the drug crisis in the United States. And we're grappling with confronting racism as a profound public health crisis manifest in the stark racial disparities in COVID deaths we are witnessing, as well as the mental health consequences. The work of our forum has never been more pressing and important. In that spirit, I am very much looking forward to our conversation today and to the work ahead. I want to quickly move into our sessions. We have some great ones, but let me first thank the sponsors of our forum who are listed on this slide. Without the support of our sponsors, none of this work would be possible. So we are so grateful to these wonderful individuals and organizations that have been a part of this work. The mission of our forum is to provide a structured environment and neutral venue to discuss data, policies, practices, and systems that affect care for mental health and substance use disorders. Our statement of task and other information about the forum can be found on our website, which you can see right here in this next link. Please note, everyone, that we are recording this webinar and the meeting materials will be made available on the event website. And now I'm very pleased to turn over the session to my co-chair, Howard Goldman, who's going to introduce our planning committee co-chairs and the full planning committee and kick off this webinar. Howard?
Thanks, Colleen. Thanks for kicking off our session today. I did want to say that those of you who are in the audience will have an opportunity to ask some questions. We will field them, and at the end of each of the sessions, we'll select some to ask of our panelists. It's my privilege to introduce the chairs of our planning committee. The members are seen on the slide in front of you. They spent quite a lot of time working together to come up with the plan that you'll hear more about from our co-chairs. But Deirdre Roach, who's a medical project officer with the National Institute on Alcohol Abuse and Alcoholism in their Division of Treatment and Recovery Research, was one of the co-chairs. And the other is Ruth Shim, who is the Luke and Grace Kim Professor of Cultural Psychiatry and professor at the Department of Psychiatry and Behavioral Sciences at University of California, Davis. So I believe that the first introducer will be Deirdre Roach.
Actually, I'm going to be the first introducer, and thank you very much, Howard, for that introduction. We are so pleased that you all could join us today. The Planning Committee has been hard at work over the past 6 months developing and organizing the workshop sessions for what was originally planned to be a full day public in-person workshop on June 3rd, 2020. Unfortunately, due to restrictions on travel and public gatherings as a result of the COVID-19 pandemic, this Planning Committee was converted to a full day workshop into a series of webinars. The first webinar took place on June 3rd, and the final webinar will be held on August 26, 2020. The main objective of the workshop and these webinars is to bring together a diverse array of stakeholders and experts to explore ways to integrate care for people with mental health and substance use disorders in primary care settings, and to contribute to informed policymaking by raising these issues on a national stage. These webinars will examine approaches to facilitate the delivery of essential components of care for people with mental illness and substance use disorders in primary care settings using 3 illustrative conditions, and they are depression, alcohol use disorder, and opioid use disorder as our framework. And now I'll hand it over to Deidre.
Well, thank you, Dr. Shin. Our first webinar explored the landscape of evolving models of care, such as accountable care organizations, patient-centered medical homes, and collaborative care arrangements, and how essential components of care for mental health and substance use disorders might be induced for those care models. The webinar also addressed the policy issues related to implementing these models and the essential components of care. Today's webinar will highlight the essential components of care for depression, alcohol use disorder, and opioid use disorders in primary care settings, and will also identify the key factors that support or impede implementation of these essential components of care. The third webinar on August 26th will explore improving the workforce to support the provision of the essential components of care. The third webinar will also focus on addressing financing, payment, practice, and systems-level issues, policies, and incentives to support the provision of essential components of care. The National Academies will publish a proceedings from the webinar series, which captures the key themes and issues of the discussions across the 3 webinars. This will be available for free download from the National Academies website. We would now like to introduce the moderator of our first session, Dr. Howard Goldman. Dr. Goldman is professor of psychiatry at the University of Maryland at Baltimore School of Medicine, and as noted earlier, is the distinguished co-chair of the Forum on Mental Health and Substance Use Disorders. Welcome, Dr. Goldman.
Thank you, Dr. Roach. I'm glad to be back here in this moderator role and kicking off this particular webinar, which, as Dr. Roach said, is focused on essential components of care for 3 key conditions. We're interested in how primary care practitioners and settings can do a better job with treating behavioral health conditions in primary care settings. The essential components of care were laid out in a foundational paper that we had presented by its authors, Drs. McGinty and Dommett. And our panelists today are going to elaborate about their understanding of the components of care for these 3 illustrative conditions, to highlight some of the cross-cutting components of care, their own understanding of these essential components, as well as differences that might exist amongst those or between those conditions. We want to examine the differences among them in primary care settings, and those with substantial resources, but also those with very limited resources. We want to explore these issues that are important to prevention, screening, and case identification. And in order to do that, we've gathered 4 experts to serve as our first panelists. They will each make 7-minute presentations, and then I will ask some questions of them and have some discussion. And at the end of that period, as I said, we'll turn to you, the audience, and take some of your questions. The four speakers that we have in this session are all physicians, and they're all affiliated with medical schools. I'm going to just identify them in order, and then we'll just move, hopefully seamlessly, from one presentation to the next. The first speaker is Richard Seitz of Boston University School of Medicine. Our second speaker will be Sarah Wakeman, who's at Mass General Hospital and Harvard Medical School. Lydia Schwastiak is at University of Washington. And Frank Degree is from the University of Colorado School of Medicine. So to start off our presentation, we'll hear from Rich Seitz.
Thank you, Howard. I'll be talking about the essential components of care for alcohol use disorder in primary care settings. And I thank you for the invitation, and good morning to some of you, good afternoon to the rest of you. I just wanted to start by telling a brief anecdote. I saw a paper in a major medical journal validating a screening tool for alcohol and other drug use disorder. And I and a colleague decided to point out to the editor of the journal and to the authors of that paper that the screening tool really was just about identifying the disorder, and not about identifying the full spectrum of unhealthy alcohol use. So we wrote a letter to the editor, that's Jennifer McNeely and I, and if I can have the next slide. We pointed that out, and the editor wrote this, that we were correct in terms of terminology. However, quote, in practice, it can be very challenging to distinguish between substance use and a substance use disorder, end quote. And I have to say, I was shocked, really shocked, that an editor of a major medical journal would admit and write down that it would be hard to tell the difference between substance use and substance use disorder. It's almost like saying that you couldn't tell the difference between high cholesterol and myocardial infarction, or an elevated glucose and a diagnosis of diabetes. And if I can have the next slide, please. It's similar, that is, alcohol use disorder and the whole spectrum of unhealthy alcohol use, which includes lower risk use, and then risky use, which you see in the orange, and then alcohol use disorder at the tip of this triangle where there's more frequent heavy use and severe consequences. These are clearly different things. And it's not that hard to identify the difference between someone who's drinking too much and someone who's drinking with consequences. And it struck me that this is a real challenge that we have on the one hand. On the other hand, in primary care, we're really, really good at differentiating between risk factors and disease. And parenthetically, I am a primary care physician myself. Can I have the next slide? So these are what I would identify as the essential components of care. And I think the main point that I want to make in my remaining 5.5 or so minutes is that these are similar components of care across many conditions, medical, psychiatric, and otherwise. What we want to do with alcohol use disorder is identify it. And to identify it, there are some fairly simple tools. In fact, one single item. How many times in the past year have you had 5 or more drinks in a day for a man, 4 for a woman, is a simple validated screening test. There are more complicated screening tests that can be used that give you a little bit more information. And once identified, you'd want to know if there were any consequences of that excessive use to see whether somebody falls into the category of alcohol use disorder or not. And you can do that by discussing the criteria for alcohol use disorder, 11 of them that appear in the DSM. Once you've identified alcohol use disorder, then you would discuss diagnosis and treatments. Just like if you had an elevated blood pressure several times, you would then discuss the possible diagnosis of hypertension and what treatments might be available. Now, some of you may be thinking right now that when you present the diagnosis of alcohol use disorder, sometimes patients will say, no, that's not me. I don't have that. Other people drink more than me. And even if you think I have that, it's not something I really want to address right now. It is true that with some other medical conditions, people immediately accept the diagnosis and want treatment immediately as well. But you may be surprised that motivation to change is not so much different for people with alcohol use disorder as for hypertension. Many people with hypertension will say, I don't feel anything, I feel perfectly fine, right? So it's not that much different. So we discussed the diagnosis and some of the treatments. And one big difference I would make between what I'm calling essential components of care here and the famous SBIRT, or Screening Brief Intervention Referral to Treatment model, is that I think we ought to include treating alcohol use disorder as an essential component of care. And although I'm an addiction specialist as well as a primary care physician, I'll say that treatment for alcohol use disorder is not really that complicated. There are 4 available medications, and then one can just monitor response by asking about drinking, side effects of medications, and challenges and successes that the patient is having. And then if they need more than I can offer as a primary care physician with my brief counseling and repeated counseling and medications, I can refer them for specialized treatment, which is the same as I would do if it were high blood pressure. Can I have the next slide, please? So this was one of my favorite papers ever, done by a medical student, published in Journal of General Medicine some 15 or so years ago. And they were audio recordings of patients and doctors who knew they were being recorded. The patient here says, 6 beers, maybe even 8. And the doctor says, okay, have you been able to take your medication? And no other mention of drinking during that visit. The next patient says, well, you know, doc, I've been boozing. And the doctor says, I know, I'm more concerned about your kidney function. The point of me sharing with you this famous qualitative study is, next slide, that we have a task to perhaps convince ourselves that treatment of alcohol use disorder is not so much different from the way that we identify high blood pressure by checking a blood pressure, or diabetes by initially screening with a blood sugar, and then discussing the diagnosis, and that it's a real diagnosis, and that there are treatments that are effective, and that we're going to give those treatments and monitor them for response, much as we would, even including psychosocial and behavioral counseling components for those conditions more traditionally thought to be classically medical, and then refer when it's beyond our own expertise or when there's complexity. And yes, there's multimorbidity, but primary care docs, we know, are really good at multimorbidity and prioritizing. Next slide. So I'll leave you with the question, why aren't we doing this? I think primary care docs can do this. And often it comes up, well, we don't have enough time. I can tell you, I have never heard a primary care doc say they don't have enough time to treat hypertension or diabetes. We don't have enough resources. That may be true for some specialized resources that we need to organize using the models that were described in the first webinar, like the chronic care model. And we use those for other conditions. It's much harder to get somebody on insulin for diabetes, frankly, than it is to prescribe daily naltrexone for alcohol use disorder. And I think what we need to do, and this is maybe hypothesis generating, is to target primary care physicians like myself's role responsibility. Is it really our job? I think it is. I think we can make the case it is. And therefore, we need to address that role, address stigma and systems, and then the more complicated question that hopefully some others will address, and some was addressed in the original webinar, how to do so. And that's all I have. Thank you.
Great. Thank Rich Seitz. Thank you very much. We'll now hear from Dr. Sarah Wakeman.
Wonderful. Thanks so much. And thank you for joining us today. It's always a pleasure to hear Rich speak, and I think he laid out the case beautifully. I'm going to try to build off of that to talk about how we use really those foundational elements to make a case here at Mass General, where I work, in our substance use disorder initiative, one component of which was integrating care for substance use disorders across primary care. Next slide. So I think when we think about making a case to our primary care doctors, I think the first piece that we think about is the why. Why should they care? To Rich's point, I think we think about this a lot with our patients. It doesn't really matter why I, as a primary care doctor or addiction medicine doctor, think a person should make changes to their alcohol or drug use. It only matters if they think that their life is somehow going to get better if they make changes. And similarly, I think it doesn't matter that I think all primary care doctors should be doing this. The point is, why might primary care doctors think that this is in their purview and as important as treating diabetes or hypertension? We're in the midst of really 3 devastating public health crises, I'd argue. One is the overdose crisis, where more Americans now die from drug overdose than from the peak number of deaths due to HIV, gun violence, or car accidents. We saw a brief dip in the numbers in 2018 and unfortunately a rise last year in 2019. And already projected numbers are looking worse in the context of COVID, with worsening social isolation, economic inequities, despair, and racism. Next slide, please. The third public health crisis, in addition to COVID and the drug overdose crisis, has been with us since the founding of this country, is racism, and a string of deaths of Black people at the hands of police, as well as the racial disparities in the impact of COVID-19 on Black and Latinx communities, has reminded us of the health toll of living in a racist society. As an addiction medicine doctor, I practice in a field that unfortunately is closely tied with racism. Our drug policy in this country has its roots in racism. People of color experience discrimination in every component of drug policy in this country, and at every stage of the criminal justice system. They're more likely to be stopped, searched, arrested, convicted, and harshly sentenced for drug law violations. And when we look at people in prison for drug-related crimes, the majority of them are Black or Latinx. In addition, there are other systems that are labeled as systems of support, but honestly, if you dig beneath the surface, have a lot of echoes of carceral systems like our criminal legal system. For example, in our foster care system, 80% of cases involve caretaker drug use allegations, and the vast majority are low-income Black, American Indian, and Latinx individuals. You can see here the huge disparity in the rate of child removal based on race in this country. And so that's the other real why here. So this is a crisis. Overdose deaths are a crisis, but racism is a crisis that's always been with us. And if we're going to talk about racism, we have to talk about drug policy. And part of that is about identifying and treating those who do have drug use disorder and substance use disorder as having a medical condition. Next slide. The other why here is that we know we can do this, and Rich touched on this. It's not that complicated. We do way trickier things all the time in primary care. It's much harder to think about safe management of anticoagulation or insulin titration, management of heart failure. All of these things that we are very skilled and adept at doing are much trickier than managing opioid use disorder or alcohol use disorder. The reason I think we feel like we don't have enough time or we don't have the skill set is largely because it hasn't been taught in our medical school education or graduate medical education, but also because the medical system has sort of been given a pass of thinking of this as a medical condition or something that should be a part of our toolbox of what we normally address within general medical systems. And yet there have been study after study looking at, in this case, opioid use disorder, but also alcohol use disorder, showing that we can effectively treat this in primary care. Actually, outcomes are as good as specialty care settings. So this is a study looking at buprenorphine treatment in primary care with or without adjunctive addiction, psychosocial treatments like cognitive behavioral therapy, and showing no difference, that we can manage these conditions in primary care. And in fact, that's often where patients want to get their treatment, with the doctors and the care teams that they trust. Next slide. I think the other important piece is we can do this, it's important to do this, and we need to reframe the way we think about caring for people who use substances, and also the ways that we inadvertently harm people who use alcohol and drugs in our healthcare system. As Rich identified, I think it's often very helpful to identify discrepancies in our approach to people who use substances versus our approach to other health conditions. I often use those metaphors as a way to really get people to think critically about the way we're caring for people who use drugs. So for example, if a person came into the hospital with an MI and had recurrent chest pain in the hospital, we wouldn't discharge them against medical advice. And yet if a person with a substance use disorder is in the hospital and is having ongoing substance use, often the response is this punitive one of actually kicking people out of care or forcing them out of care. We spend a lot of time talking about the harms of alcohol and drugs on people's health, but in fact, a lot of the health consequences of substance use are related to our policies and our approaches. People don't get infective endocarditis from heroin. They get infective endocarditis because we don't have access to safer injection equipment, because we don't have supervised consumption sites in this country, because we have a contaminated drug supply and and a punitive drug policy approach where people have to use in secrecy, use alone, use in unsanitary conditions. And even in the healthcare system, we often treat people who use drugs or people who use substances differently than other patients. We have different approaches to whether they're allowed to have visitors in the hospital. We might involve police and security in their care, which we wouldn't do for another patient. Again, we might have approaches that push them out of the hospital prematurely. And in those ways, actually the health outcomes and the health harms of someone's substance use are more related to our approaches to discrimination and stigma than to the actual substance use itself. And so when we think about building a system of care that treats substance use disorder for those who have it as a health condition and delivers effective medical care to all patients who use substances, recognizing that they value their health and have the same right to good health care as any other person, we need to really think about what is a patient-centered and patient-guided care framework. And that, like with any other problem, recognizing that the patient's most important needs are the thing that we have to focus on first, not necessarily what we as a provider think is the most important need. Next slide. So at Mass General, we tried to take this approach of first sort of making the case, why does this matter? It's the right thing to do, but it's also the smart thing to do. If we want to take better care of populations, if we want our patients to be healthy and we want to be able to keep them out of the hospital and reduce healthcare costs overall, we must address substance use disorder. We have to identify it, diagnose it, and treat it effectively. So first to make the case, and then to give our providers and our care teams the tools so that they can actually do this. I think one reason providers tend to turn away and blame the patient is that they feel helpless. They feel like they don't know what to do when they're faced with a person who's actively using substances or having substance-related harms to their health. We've integrated this model across our care system, from our inpatient hospital to caring for pregnant and parenting women and families, our emergency room, our low threshold bridge clinic, which is sort of an urgent care clinic model, and then importantly in primary care, where we've created teams of addiction champions with primary care doctors, nurses, behavioral health colleagues, and recovery coaches who are people with lived experience themselves of a substance use disorder, all thinking together in a multidisciplinary care model, much like how we think about diabetes or HIV care, to deliver this treatment right in the primary care setting. Next slide. I think it also helps to study this, writing about these models and also evaluating them and figuring out what's effective and what isn't is helpful in making the case to institutions from sort of the value angle, but also to the people doing the work to let them know whether or not what we're doing is actually helping. This was one of our evaluations of this integrated model in primary care, looking at practices with and without this integration of substance use disorder care, and finding that patients with substance use disorder who received care in a practice without integrated substance use disorder services had a higher number of emergency department visits and a higher number of total inpatient bed days. Next slide. And then lastly, data goes a long way, and depending on who you're talking to, but I also think narrative and patient story is incredibly valuable in terms of spreading hope and giving people sort of a tangible reminder that substance use disorder is a highly treatable condition. This is a good prognosis disease. I don't think many of our providers, when they hear about someone who's injecting heroin or fentanyl, that the first thing they think is, wow, that's incredibly treatable. And yet it is. Most people will achieve remission, will go on to live healthy lives, and it's incredibly rewarding to be a part of that as a care provider. Having our recovery coaches embedded in our system has been one really powerful way to constantly, on a daily level, remind people of that message of hope. This is a quote from a recovery coach, we have 14, about being in long-term recovery and about the value and importance of receiving treatment in the healthcare system, of buprenorphine treatment for opioid use disorder, and of how transformational that care integrated into primary care has been for her and her life going forward. And that is all I have for you. Thank you very much.
Well, thank you for that hopeful presentation. We'll shift our attention now to Dr. Lydia Schwastiak from University of Washington. Lydia?
Thank you, Howard. And I just want to thank the Planning Committee for the opportunity to participate in this important discussion. So we're going to shift gears and talk about integrated treatment for depression. And over the next several minutes, I'm going to focus on one specific integrated care model, the collaborative care model. And this is because the majority of integrated care interventions that have been shown in clinical trials to improve depression outcomes have been some variation of collaborative care. So I will briefly explain this model and its evidence base, but then describe the core principles that we've learned are important for effective implementation, and then some lessons that we've learned from research trials and implementation projects at the Ames Center about barriers and facilitators to implementation. So next slide, please. So evidence from more than 80 randomized controlled trials supports the effectiveness of collaborative care for improving depression outcomes. The first randomized controlled trial was the IMPACT trial, which was a multi-center trial of 2,000 patients at 8 healthcare organizations. And in this trial, as the figure on this slide shows, at all 8 organizations, compared to patients who received usual care, those who received collaborative care were twice as likely to experience a depression response or remission after 12 months. And since 2002, when the IMPACT trial was published, there have been almost 100 randomized trials that have demonstrated the effectiveness of collaborative care for treatment of depression and anxiety. Next slide, please. So collaborative care, so what is collaborative care? It's derived from the chronic care model, and it's a complex model with multiple components. But there are 5 core principles that provide the foundation for effective implementation. So I want to talk through those and talk about how they're operationalized in the model. First, it's a person-centered team approach, including dedicated care management. Second, it involves population-based identification of patients who need treatment and monitoring of their outcomes in a registry. Third, it involves measurement-based treatment to target, measurement-based care to track response to treatment and identify patients who are not improving so that timely adjustments can be made to their treatments through a systematic review of the caseload by a psychiatrist. And fourth, evidence-based treatments for depression and anxiety, including brief behavioral interventions that are feasible in primary care settings. And fifth, that it's accountable care. So on the next slide shows the first 2 principles, that collaborative care adds 2 new members to the primary care team that's treating depression, a behavioral health care manager who works in the clinic, typically full-time, often a social worker, and a psychiatric consultant who is not in the clinic, does not see patients directly, but spends 2 to 3 hours a week working with the clinic, including a structured weekly meeting with the care manager for caseload review. The care manager has 2 sets of tasks: general care management, like tracking and coordinating care and systematic follow-up, but then also to provide evidence-based brief behavioral interventions for depression or anxiety. And the primary care provider is a critical member of the team and continues to prescribe and monitor all medications. The second principle of population-based care involves systematic identification of patients through routine screening for depression, and then using a registry to track response to treatment for all patients who are in care. Next slide, please. So collaborative care is not only twice as effective as usual care, but importantly, it reduces the time to depression response and remission. And data from a large statewide collaborative care implementation project in Minnesota showed that over 5 years, among 7,000 patients, the mean time to remission among those who received collaborative care was less than 3 months, compared to more than 1.5 years for those in usual care. A typical course of treatment in collaborative care is 6 to 12 months, and what we've seen is that 50 to 75% of patients in treatment will need at least 1 change of treatment during that time. So timely treatment adjustments are critical to reduce the time to depression response. And this is operationalized in collaborative care through measurement-based care and treatment to target. They're implemented together in collaborative care. And briefly, they involve the use of validated rating scales like the PHQ-9 to monitor outcomes, and also defining a measurable target for treatment, such as a PHQ-9 less than 5 for depression remission, and then monitoring the outcome at clinical visits with regular review to identify patients who are not improving as expected, and then importantly, adjusting treatment iteratively until the goal is achieved. So, but measurement-based care and treatment to target are only as good as the actual depression treatment that's provided. And evidence-based treatments are the 4th core principle of collaborative care. So in addition to guideline adherent medications for depression, brief psychotherapy interventions are also offered in collaborative care. But these need to fit a treatment schedule that is 30-minute visits every other week. So structured, manualized treatments work best, like problem-solving therapy and behavioral activation. Next slide. So this is accountable care. It increases access to care. There's systematic approach to identification. And importantly, there's a continuous QI approach to both treatment of individual patients, but also evaluation of program performance, which is really critical for effective implementation. Next slide. So collaborative care, like any evidence-based intervention, needs to be adapted for the specific setting where it's being implemented. So the core principles that you see in the middle have to be maintained for fidelity, but every implementing organization makes some changes to the model. And on the next slide shows that both structural elements and process of care elements facilitate effective implementation. So in our experience, adequate staffing and adequate time and training are essential for effective implementation of the model, as is effective use of a registry. And mechanisms for financing are critical to sustainability of the program. In terms of process of care elements that facilitate implementation, a standardized screening and referral workflow is important. And not only training the teams, but providing them with ongoing support through implementation. And operationalizing accountability. And we found that audit and feedback works very well for both continuous QI approach to program evaluation. So on the next slide are some of the barriers that we've encountered in research and implementation projects, particularly in rural and frontier communities, and some of the strategies that have helped us to address these barriers. So first, inadequate staffing. Workforce shortages can make it very difficult to hire a care manager or identify a psychiatric consultant. Secondly, having a model that addresses all the needs of patients who have complex comorbidities and chronic psychosocial stressors. And then third, the inadequate financing mechanisms has been a huge barrier to implementing and sustaining collaborative care models. But some of the strategies, some of what we've learned over the last decade or so is that telepsychiatry can extend the reach of mental health specialists like psychiatrists. And in our large statewide program in Washington State since 2008, psychiatrists who are based at the University of Washington provide consultation to over 100 community health centers across Washington State. And there's even evidence that the care manager role can be effectively delivered virtually. And so, especially given changes related to COVID, telepsychiatry is likely to be increasingly important. Second, more recent research has focused on developing and adapting models to co-manage multiple conditions, such as our team's work in co-managing depression and diabetes. And these models also need to systematically address social determinants of health, which has been very challenging. But finally, to think about financing, the 2017 CMS billing codes for collaborative care have been a major advance in implementing collaborative care. These codes have been adopted by Medicaid programs in 14 states and some private payers. They're billed to the primary care clinic, and clinics must have multiple processes and structural elements in place, but there's increasing uptake of them. It's been slow, and I think in our discussion, we can discuss some experience with billing these codes. So I'll stop there and thank everyone.
Great, thanks, Dr. Schwastiak. We'll get back to that billing code issue, I think, in our discussion period. Our final presenter is Dr. Frank Degree, and he's up next.
Thank you. You can go to the next slide, please. I want to start by thanking Richard and Sarah and Lydia, and underscoring, before I disturb everything, underscoring that I agree with all of the approaches and all of the points, and I'm a personal witness to the success of all of these interventions in the context of primary care. I have spent a lot of energy as an old family doc who's a mental health services researcher, trying to stand up and live inside primary care clinics as they exist, free range, community-based primary care clinics as they exist out in the world, to understand what happens when we try to do things like the interventions we just heard. Why do they work? And we get agreement from the clinicians that they work, but they don't last. What are the elements of success that are in common across all of these, and what is it that keeps them from sustaining after we demonstrate success. So I want to try to cut this a different way and see if we can understand what happens in actual primary care clinics when we create successful interventions like this. I think that clinical interventions that peel away from a patient a diagnosis and set it apart to be dealt with as a thing in its own right, not only are only successful when that condition dominates all the other problems that a patient has. It works great for cancer or maybe an MI or acute cholecystitis, but for the average 55-year-old primary care patient with 6 chronic problems and a life full of woes, it's very hard to stay focused on just one problem or treat one problem in isolation. Next slide, please. This difference between problems that patients have and the patients themselves is really important. It's not just consultants who are primarily interested in a problem that might occur in primary care. We do it ourselves. I have done it myself. I did that for years. Early on in my career, I identified somatization as an especially important problem and developed beautiful, effective interventions for somatizing patients. Same thing with depression. First, second, third generation interventions for depression. Clinicians will say, this is great, I'll use it. And then you come back to those primary care practices 6 months or a year later, and what you see is the practice has drifted back to pre-intervention workflows. And it gets sort of buried back into the swarm of things that we primaries have to deal with for our patients as most important or most urgent that day or during that episode of care. Embedded behavioral clinicians and embedded care managers in particular in actual practice are primary care clinicians. They get pulled into all of the other noisy, dirty problems that are more important at that moment and have great difficulty staying focused on the original problem that they might have been hired or organized into the practice for. Next slide, please. So I have a particular affection for and affinity for the collaborative care model. Wayne and Jürgen are 2 of my friends and heroes. I grew up with Wayne. He was an important mentor to me, and I grieved when he died. And I'm going to pick on that problem in particular because I spent a lot of time, and I am currently attached to the variations on that. But this applies equally to Richard's and Sarah's descriptions of how we think about the problems that they illustrated with alcohol and substance use equally. What I'm describing here is why we can't retain fidelity to interventions that work. Why does the regression or the slippage happen? I think that it has something to do, as I just said, about focusing on patients over problems. But there's a real interesting slippage. There's an objective data point that sort of illustrates how difficult this is for ordinary primary care practices. The 2,900 primary care practices that were enrolled in CPC Plus last year, over 95% of those practices achieved some behavioral integration, but only 700 of them, less than 1/4, were using anything like the collaborative care model, despite it being the only model that was offered for the first 3 years. If we can go to the next slide, please. I'll describe sort of what I think is happening in the real world with that slippage. We can learn something about that by visiting an organization called the Collaborative Family Healthcare Association, CFHA, which is a 1,500 member multi-guild organization that's been running for about 25 years. It's frequented by true believers in integrated behavioral primary health care. These are high-end clinicians and educators and researchers and policy people who are looking for whatever way they can to bring behavioral health care into primary care. A lot of high-end people have attended their annual meetings over the years. I've watched for the past 15 years the patterns of adoption amongst this membership, beginning with the first and second generation collaborative care models presented by Wayne and his colleagues, with those beautiful, elegant clinical trials that are utterly persuasive. The dominant models have more or less dramatically shifted recently because of implementation problems to a widespread adoption of something that they're mostly as a shorthand calling integrated behavioral care, care, PC in primary care, PCBH, so forth. It's a primary care clinic with an embedded behavioral clinician, usually a psychologist or a social worker, with or without a psychiatrist or a psych NP to kind of cover the deep end stuff, and a care manager. So the next slide, please. And there's interesting evidence about whether that kind of model of integrated care works, is effective for addressing depression, anxiety disorders, substance use disorders, alcohol. And the literature is kind of weird. It exists, but it's kind of weird because you aren't looking at a single intervention across all sites. It's not disease specific. You're looking at integrated care as the active ingredient, applied differently in different practices to different conditions, according to that site's most pressing problems or according to the patient's most pressing problems. In other words, the basic idea of a controlled clinical trial just can't be stretched to fit patients and clinics' different and changing behavioral health needs. So here's what you can do to get started in looking at this literature. You can go to the Journal of the American Board of Family Medicine, JABFM. In September of 2015, they published a supplement, a special issue. The whole issue is devoted to papers from the ACT trial, Advancing Care Together. It was a statewide trial done in Colorado that actually produced about 25 papers and a book about this trial. And if you actually want more about what that evidence and what that data looks like, you can go to ARC's Integration Academy. There's a website there, it's on the slide here. And where there's a collection of the world's English language literature on integrated care that focuses on the evidence in support of various models for various conditions and for various clinics. Next slide, please. I'm going to end by just making 4 suggestions. The first one is, I think we have to understand the work of primary care clinicians and reconceptualize interventions according to our revised understanding of what the basic work is. If we wish to develop interventions that fit into their work and into their workflow and sustain, I think dealing with disease-specific interventions is not likely to ever get us there. Second thing is, this is going to wreak havoc with much of our research design methodology. Clinical trials, controlled clinical trials are likely to, they're best deployed when the intervention can be standardized, when the target population, the target problem rather, is so singular and dominant that the context of comorbid conditions and family, social, environmental factors that affect that target are in effect irrelevant. And that doesn't describe usual primary care. You can create that artifact when you're dealing with a specific problem, but it doesn't last. The third my third point, my third suggestion is that disease-specific outcome measures are at best insufficient and at worst inappropriate and crushingly burdensome. Primary care's demonstrated value to individuals and populations lies not in its ability to produce improvements in disease-specific outcomes, but in overall health and longevity. And number four, we need to quit being half-assed about mustering resources to actually develop and stabilize a sustainable model in primary care. Most primary care practices are operating right up to their gills, and they just don't have the margin to plan and implement a workflow change, then fit that into their other workflows, then enjoy sufficient revenue from that added set of tasks to keep it as a first priority. We've got to quit trying to get quality on the cheap. We've been getting what we pay for. I believe Richard and Sarah and Lydia have each described for us enormously successful interventions that will work in primary care. And if we can expand sufficiently the resources within primary care to keep those as priorities, in addition to the other demands that are made on primary care, those will be sustainable interventions. But so long as we expect primary care to contend with the tsunami of demands and expectations that keep pouring over the transom of what else needs to be done there, these aren't going to be sustainable interventions. Thank you.
Thank you, Frank. I want to stick with you. I'm going to ask all the presenters to turn their cameras back on and try in this virtual space to get something like a semblance of cross discussion. But I wanted to stick with you, Frank, because there's some inconsistency I experienced when I listened to your presentation. And I'm going to give Lydia a chance to respond to this because she's been offered here as the champion for collaborative care. I guess I'd put myself in that same camp as well. I don't quite understand why the IBP-HC or any of the integrated models are any easier, are going to overcome in any way the difficulties that you characterize about implementation of collaborative care with Fidelity. And I also don't quite understand how they'll be financially sustainable, given what we started to hear from Lydia. And again, I'm going to ask her to elaborate on.
Yeah.
So I'll give you a little bit of time here, and then we'll go to Lydia.
Okay. Financial sustainability is a really important issue here. And I think it is possible, and in fact, I know it's possible, to render a primary care clinic financially sustainable with the addition of care managers and behavioral clinicians by 3 or 4 mechanisms. First of all, it's possible to increase the billing. If you live in an old RVU-based system, and many of the primary care practices that I work with and am familiar with do, the addition of a behavioral clinician who's essentially available for dealing with complex behavioral issues of whatever nature generally produces an increased productivity, increased volume of care amongst the partnered primary care clinicians of 1 to 2 patients per half day, which is sufficient to cover the cost of that clinician. Many of our behavioral clinicians are now on behavioral panels, and they basically get paid for the work they do. Social workers get paid on an incident to billing basis. And so what we notice is efficient team-based care is sufficient to cover the cost of the team members who aren't necessarily able to bill. I believe, and what I'm noticing in most of the integrated care models, is that when there's a clinic or when there are clinicians within a clinic who are particularly interested in substance use or depression plus diabetes, and that becomes a focus of interest in that clinic, what the models of care look like is a hybrid between what we've got with collaborative care, where you've got a registry for depression or a registry for depressed diabetics, and an interested psychiatrist and an embedded clinician and a care manager paying particular attention to that Plus, that embedded clinician will be paying attention to the other primary care type behavioral problems. I noticed hybrid models, and I think we're getting into a first generation of integrated hybrid models, depending on what the area of emphasis or this year's quality improvement condition is. But if you just leave primary care clinics to their own devices, those embedded behavioral clinicians generally take on whatever patients come in with. So dedicated and partitioned out, integrated care around single conditions tends not to get the kind of attention it does when it's part of a integrated, essentially a clinical trial.
Great, thanks, Frank. You know, one person's hybrid program is another person's drift from a fidelity to an evidence-based model. So I'm going to give Lydia a chance to respond both to the specifics of Frank's last comments, as well as to the issue you alluded to earlier about challenges in using the new financing mechanisms. Take it away.
Yeah, thanks, Howard. There's a lot there. I think getting to your original question to Frank and me, I heard two questions. One was that the collaborative care model has been criticized because it's complicated to implement, and there are challenges to implementing it. And why would any integrated care model be less challenging to implement? And then specifically related to the financing mechanisms. So I think these are challenging especially when I think about our work in rural and frontier communities in the Northwest and in Alaska, some of the work we've done in low and middle income countries. Any model that involves bringing a mental health specialist into the primary care clinic is going to be limited by workforce shortages. So I think that's a major challenge to the integrated behavioral health model, in addition to the collaborative care model. And then with respect to financial sustainability, the CMS codes were really a game changer. I mean, just in thinking about the collaborative care model has been around since 2002. And, organizations have tried to be very creative about how to financially sustain it. But with the coming of the Medicare codes, there's been increasing uptake. It's a primary care time-based code that you can actually bill for services that previously weren't billable for, like care management. And we can have unlicensed care managers, and it really has dramatically shifted the implementability of the collaborative care model. With that being said, I think some of the major barriers are the administrative burden of billing it as a primary care code, the structural elements that need to be in place, and also this, the multi-payer component of it. I think with primary care organizations that are trying to provide care to very complex patients, the idea that they can bill Medicare patients but not Medicaid or private patients for particular services just becomes really overwhelming. So I think the multi-payer component of it is still a big challenge, as well as I think the administrative burden is becoming less so as these strategies are being worked out. There's a lot to say about the Frank's comments and the idea about, are we flexing the model versus drifting from fidelity? And I think that's a webinar topic in itself, about how far can a robust model be stretched. And I think, we've really tried to be creative, maintaining those four core components. That there has to be a registry, there has to be expertise, there has to be evidence-based care for the conditions that you're treating, and treatment to target for those conditions. That then you can, we've tried community mental health settings, we've tried multiple different populations, complex comorbidities, opioid use disorders. I mean, it's, I think it's worth trying. It's an effective model. It's worth trying to stretch it, but that's the tension.
Right. I was very impressed when we did the implementation analysis of the original impact study. the fact that it was implemented successfully in such a wide array of primary care settings, multi-group practices, the VA, Kaiser, private practice models. That was one of the things that the robustness was impressive to me. I want to stick with you for 1 second before I go to Sarah. So I'll get to you, Sarah, with a question. And that is, what kind of adaptations do you have to make if you follow Frank's lead to not being so disease specific and you expand it to other behavioral health conditions or to multiple comorbidities? I mean, after all, the chronic care model that Ed Wagner developed with Wayne was for several chronic care conditions: diabetes, chronic obstructive pulmonary disease, rheumatoid arthritis, as well as depression. Can you give us a flavor for the adaptation?
Yeah, I mean, I think there's a lot of different answers to that question, but kind of thinking about what is it about the context that you're implementing? What are you trying to treat? What's the context of the clinic? What's the nature of the team? So, you know, in thinking about work that we've done to not just treat depression, but co-manage depression and diabetes, moving it into diabetes specialty clinics, that is a completely different workflow and a completely different, you know, a different workforce. And so I think the adaptations, we really try to stick with the, you know, as I just said, we really try to stick with those major, the core components, and then how does it have to be adapted for that context. So, you know, some of the work, a project we recently completed was treating diabetes and psychosis in community mental health centers, and really thinking that's a very different, it's not even primary care. And so, you know, just kind of thinking about where's the red, you know, can we get back to where's the treatment to target? What's the caseload review? Who are the experts who are involved in supporting the management? So I think it really is, you know, it's sort of learning from implementation science work that's been done over the last decade or more to understand how to flexibly adapt. What's the core component of the evidence-based intervention, and then what can be flexibly adapted in the periphery.
Great, thanks a lot. I want to shift gears here a little bit. Frank, if you can make it short, I want to get to the rest of the folks, and we've got also, I want to make sure that people in the audience know that this is the time to submit your questions that you have. We'll have about a half an hour to have the panelists address your questions. Frank, you want to rebuttal quick before I go to Sarah?
Oh, not in the least. No, I think Lydia, I want to draw a line under what she just said about implementation science. I think in a sense, this is the key to adapting what started out as pure culture, collaborative care model to the range of variation that occurs in natural primary care settings. If we can get a hold of the principles of implementation science and take advantage of how you have to not retain fidelity to an intervention, but adjust it to the context in which that intervention occurs, that's the key to adapting this to ordinary primary care. I believe that's our way forward. That's all I want to say.
Great. Thanks, Frank. Sarah, I was very hopeful when I heard your presentation. Almost 50 years ago, I was working in the emergency room at Massachusetts General Hospital. And our attitudes about people with alcohol use disorder or opioid use disorder was not so welcoming and not so inspired. I was very interested in your comments about racism and structural racism in particular reflected in policies. Can you tell me what you as a group within Mass General, or more broadly, your institutional affiliations are doing anything about changing those policies?
Unmute myself. Two pieces in that question to respond to. First is the how do you change the outright discrimination and stigma that people who use drugs or people with substance use disorder experience when they come into the healthcare system. And then the second piece around structural racism, those two are interwoven, but also sort of, you know, have slightly different answers. On the emergency room piece, you know, I think a lot of what's being echoed throughout here are finding champions. We haven't really said that, but having champions is an important part of this work. And for us, having partners in the emergency department who could be our champions and could be our peer champions, because it's much more meaningful. For example, you know, I'm a primary care doctor, and so I can understand what it's like for other primary care doctors and what those pressures are and when pushback is reasonable and when it's unreasonable from primary care doctors. But as not an emergency medicine doctor, that's a little bit more challenging. And so it's been invaluable to have our emergency medicine colleagues. And actually, one of our colleagues who was a resident at the time who had studied behavioral economics really helped us catalyze change in the emergency room. So we came up with this social media campaign called Get Wavered that was built around the principles of behavioral economics, where people were invited by their chair to get wavered to prescribe buprenorphine. So it was an invitation by an authority figure. And actually the chair was one of the first people who got wavered in the ED. So kind of putting his money where his mouth is. People were paid for their time, which is another important piece. And then they actually got celebrated when they got wavered to prescribe buprenorphine. So they got a special badge that said that they were an opioid recovery champion. They got a badge backer that they could wear on their with their hospital ID badge. They were promoted on social media and in faculty newsletters. And so it was a way of making this work that was valued and that people were recognized for and that they wanted to be doing. And then the other piece, particularly in fields like emergency medicine, where I feel like often the cases that you see are when people are really struggling, and the only people you see come back again are people who continue to struggle. And the cases where that intervention, that sort of reachable moment of the emergency visit leads to someone getting well and engaging in care and going on with their lives, you don't ever see that in the ED. And so another thing we did, because we see those people in our bridge clinic and in our primary care practices, was to feed those stories back and actually present them for a brief sort of 1 or 2 minutes at the start of faculty meetings, so that the emergency medicine clinicians felt like, wow, like I actually did something. That buprenorphine script that I gave someone, that 2 days of medication, really actually led to significant change. And so those are some of the strategies that have been really helpful for us. And now 95% of our emergency medicine attendings are wavered to prescribe buprenorphine, and we have 24/7 access in the ED. The bigger question of racism, I think, you know, is much harder. Obviously, you know, racism is embedded throughout our society and throughout our healthcare system. And we're now paying more attention to it in this sort of moment of societal awakening in the context of what's going on. And I think importantly, figuring out what are the action items. So, you know, it's not enough just to read books or recognize that racism happens in healthcare, because we know that, but really what are going to be the action pieces and how do we change that? I think, you know, one piece is looking at data, since we use data to drive all of what we do. And so inevitably, if we actually look for it, we will see that racism exists in our care system on all the components, including in our addiction treatment referrals, retention, engagement. You know, I think for a long time, people have talked about race as a risk factor instead of racism, or living in a racist society as being the risk factor. And so identifying those areas and then figuring out how to change them. I think the other piece is really our workforce, which has been mentioned, but hiring, promoting, retaining Black and Latinx leaders in addiction medicine, I think is really crucial. And that starts way early in the pipeline in, you know, medical students or even sooner. And making our spaces welcoming for people to come get their care. And that includes thinking about policies. We did a qualitative study of patients who'd left the hospital prematurely. We like to call that against medical advice, but I always think that implies that we doctors are the knowers of all things, and people are, you know, being naughty and not doing what we told them to do. But people leave prematurely. People leave prematurely for often because they feel like they're being treated poorly, or because they have competing priorities that we haven't recognized. And one of the biggest themes that I'd say the 3 biggest themes that came up, one was fear of undertreated withdrawal or pain. 2 was feeling like they were being treated differently than other patients. So if you're in bed A and you know that bed B is going down to the gift shop and to the cafe and doing whatever, and you're told that because you have a history of injection drug use and you have a PICC line in, you're not allowed to leave your bed, you know, that's discrimination, and patients feel that. And then the third is that many of our patients, because of our drug policies and our criminal legal system, and had histories of incarceration and felt like being hospitalized, the way they were treated was similar to being incarcerated, that police and security were involved, their belongings were searched, they weren't allowed to have visitors. And so I think often when you talk to healthcare providers, they think that they're doing something good by doing those things. Like, oh, I'm protecting this person from, using drugs while they're in the hospital, instead of thinking about how those actions and those policies actually hurt people. And so I think a critical examining of policies, both from a general discrimination of people who use drugs, but then from a racism lens, is another crucial component of the work.
Thank you so much for those comments. Thank you. Rich Seitz, you and I talked a little bit about the treat part and the turf part of your model. So you could elaborate a bit on what can be treated, but I'm also curious about, in your model, there's an opportunity to turf, to refer. And I wanted to know a little bit more about what you treat and what you send on to a specialty sector.
Yeah, no, I think this actually applies a little bit to Frank's comments about disease specific versus whole person. What does the primary care clinician get him or herself involved in the clinic versus referring? Are they addressing a specific disease or that whole person? I actually think the answer here is that it's not an either or situation, right? It's of course we need to do some disease specific things because there are specific treatments that improve those disease specific outcomes. And in doing so, they often do translate into overall better health as perceived by the patient if we choose correctly, right? Now, some of those things, in the case of alcohol use disorder, some I think are really quite simple for primary care clinicians to do. The medications for alcohol use disorder are not complicated to prescribe. I remember learning about depression treatment many, many years ago, and the recommendation was choose the antidepressant that you're going to get good at and that you're going to know, right? And then use that one. Well, there's really only three medicines and 4 prescribed medications for alcohol use disorder. One's injectable or oral naltrexone. There's acamprosate and disulfiram. These are not very difficult to use, and you can actually learn how to use all of them. If you're scared of disulfiram because it produces a terrible reaction when you drink, also known as antabuse, then you can leave that one for the specialists if you like. But naltrexone and acamprosate are easy to use. The injectable naltrexone is slightly challenging in primary care settings because you have to have a place to store it and you have to maybe order it in advance, and there's some complexities in getting it from pharmacies, et cetera. So, all right, so then maybe that leaves out of the 4, two pills that you can prescribe. And the brief counseling that you can do is the same as for high blood pressure. Are you taking your medication? Are you having any side effects? In the case of blood pressure, it would be checking the blood pressure. In the case of heavy drinking, it would be asking people about if they're continuing to drink heavily, and if so, why, and what are the challenges in cutting that back, or if they've had some successes, congratulating them and seeing what those successes are. I think we know that PCPs have PCPs and all the professionals that deliver primary care make different decisions based on their expertise and experience about what they're going to refer. So there will be a clinician who feels very expert at cardiac disease, and they will have a high threshold to refer. Others may refer immediately when they initially diagnose diabetes and feel like they need a diabetes specialist to get that person started. The same could be true here with alcohol use disorder and opioid use disorder, depending on the person's, on the clinician's level of expertise and comfort. But I want to throw in just one other observation that I think is related to where primary care docs and nurse practitioners and PAs make these decisions as to where to refer. And that is their satisfaction caring for patients. It's something we don't pay maybe so much attention to. We did a survey now probably 20 years ago where we asked docs, this would happen to be mostly docs and some nurse practitioners who were practicing primary care, whether they were satisfied caring for people with diabetes, high blood pressure, alcohol use disorder, and drug use disorder. And I think you can predict what the results were, although in a way they're quite odd. It was that they were least satisfied caring for patients with drug use disorder. moderately, but still not so well satisfied taking care of patients with alcohol use disorder, and very satisfied taking care of patients with high blood pressure. Now, as a primary care clinician myself, it's not that it's uninteresting, but really, prescribing a medication for high blood pressure, watching the blood pressure either come down or not on the next visit, increasing the dose, adding a second pill, it's really not that complicated or frankly that exciting. Although, you know, I like to get good outcomes and all that, just like the next person does. You know, why is that? And why aren't they satisfied? And might that make them more excited? And I know I was asked to talk about alcohol use disorder, but really to borrow from Sarah's observations and topic, some of the most satisfied primary care clinicians I've seen in the last decade have been those that have begun prescribing buprenorphine for opioid disorder. They see results, they see patients getting better, and they really truly are. I mean, I've had people come up to me very surprised at how happy and excited they are taking care of patients with opioid use disorder, and they would have never predicted that. So anyway, those are some thoughts.
That's great. A satisfied primary care practitioner is just where we want to end this particular phase of our webinar. Now, if I'm not mistaken, we're right on time to shift to the Q&A from members of the audience. I believe that they're being collected and curated. Colleen, do you want to ask the questions? And the only thing I'd have to do is moderate any further, you know, directing the question or changing. So why don't you go ahead?
Great, Howard. And I'll kick them to you and you can decide who's the right person to answer maybe, or they can decide themselves. So the first question, how can providers design essential components of care to do a better job making the care patient-centered, whether it be collaborative care or otherwise, and focused on what patients want rather than what providers think patients want? And another question on the same theme is, what are concrete steps that can be taken to be successful in helping patients feel heard and respected?
Well, I'm going to stick, thanks a lot, Colleen. I'm going to stick with Rich because I was really struck that the emphasis of your last 2 minutes was about the satisfaction of the primary care practitioner. And the audience is asking us a question like, how about what's good for the patient?
Yeah,
so
fair.
Why don't you take that first and then we'll see who else wants to handle it. This is a really interesting question, I think.
No, it's more than a fair and interesting question. And I may have gone to the clinician's satisfaction as we even pay attention to that sometimes less, but in the way that we, in the essential components of care for alcohol use disorder, and I'd also say for opioid use disorder, part of the reason I may not have said much about it is because we emphasize that so much. So one of the things I mentioned was when presenting the diagnosis, really the idea is to talk to the patient to find out what is bothering them about it. And in the case of alcohol use disorder, they may identify consequences related to their drinking, but then the discussion turns to what is it that you might want to change? And as you all know, I think motivational interviewing is one of the key ways to handle that discussion. And that mode of being with people and communicating with patients is highly respectful and really focuses on what the patient thinks and what they perceive to be the problem or the issue or the thing that they want to address. Probably the latest evidence around alcohol use disorder treatment, and there's a lot emerging just in this last year or two, is that many people can get better from their perspective while still drinking. That is, while not abstaining 100%. They can reduce their drinking substantially to the point where they are satisfied that they've achieved a good outcome, that they feel good, that their health-related quality of life is better. And so that's a way of thinking about patient-centered discussions and outcomes in determining what the treatments are going to be, and in particular, what the goals of those treatments will be.
Great, thanks. I'm going to ask Colleen, how many questions do we have, and how much do you want me to mix it up with the other participants?
we have many, many questions, and just go through them. I'll throw them out, but if other presenters
All right, then what I think I'll do is just you come up with the question, and then I'll select somebody, or somebody raise their hand if you're dying to answer this question, but I won't keep asking several people to address one question.
yeah, that
Go
sounds
for
great.
it.
Howard, can I just
Yeah,
build on
sure. I mean,
what Rich said, because I think it's an incredibly important part of any of these integrated care models is how person-centered they are, and that's the key to the care management piece of it. That collaborative care isn't one thing, and so when people engage with the care manager, it's very tailored treatment. So you may or may not take medications, you may or may not have a specific psychotherapy. So I think that's really, all of the things that Rich just described about alcohol treatment are also true for the depression, anxiety, PTSD treatment, and really thinking about, having things driven by what, and particularly for people with complex comorbidities where they're managing multiple conditions, where do you want to start? What's important to you? And I think that's critical for engaging people.
great, thanks. Let's hear the next question, Colleen.
Yeah, and the questioner did the hard work for you by referring this question to Dr. Wakeman. So Sarah, the question relates to the training trajectory. What can we do for medical students and in residency, specifically in the context of training to care in primary care for drug and alcohol use, but it certainly applies across the panel, to do a better job training folks in these essential components of care while they're still in training?
Yeah, no, great question. I mean, I think we have learned how to do this with other specialties. We, I think first need to teach it and teach evidence-based treatment as a part of medical education, which we don't. I mean, some students get an hour or maybe a half a day if they're lucky of sort of their addiction medicine time or addiction related content, as opposed to weeks of both classroom learning or book learning and then experiential learning, clinical care on the wards and in the clinic. And that just doesn't exist, that model for addiction medicine, outside of a few specific institutions. So I think that's one piece. The other is faculty mentors. We need faculty to be mentoring students and trainees and to be a part of medical education and to show that this is a rewarding and impactful career pathway to go into. And I think those messages of hope, because our students also often train in the emergency room, in the general medical wards, where if they're not seeing people offer treatment, they're getting caught in that same cycle of nihilism and pessimism, seeing people with really sort of complex, severe end stage presentations of substance use disorder where we don't treat the person, we discharge them, then they get sicker and we blame them. And that's really been the model historically when patients come in with substance use disorder. And so students see that. They also learn from the hidden curriculum. To Howard's point, if their attendings and their senior residents are making snide comments or calling people, quote unquote, drug seekers, or using stigmatizing language towards patients with substance use disorder, students soak that in. So that's certainly not a message to people that this is, a compassionate, wonderful field to go into. So I think there's lots of things that faculty and institutions can do. I do think that students get this. I mean, a lot of our students, they are passionate about social justice. They recognize that the overdose crisis, that drug policy, that systemic racism, that these are the issues of our time. Much like, when I was in medical school, everyone wanted to go into global health and HIV. That was like the thing. And I think people get that this is a social justice issue. And so I think letting that energy guide us, and sometimes that can help motivate faculty members to get on board, but we need that at every level.
Thanks, Sarah. Colleen, you got another one?
I have there's so many good questions in this feed, and it breaks my heart that we're not going to be able to get to all of them today. But the next question goes to the question of value-based care and the value-based care framework, and the ability to focus on high needs patients with complex care needs in a high value way. Do you see that insurers are more focused on value, and how might that help us push models like integrated care models, collaborative care models?
With a show of hands, somebody want to take that one? Anybody interested? Too challenging. Well, it's so challenging. I'll make Frank do it. You have a thought?
Yeah. I happen to live in an environment where value-based care isn't exactly, we're not on the leading edge here, but I do have some thoughts about this. I made a comment in passing about outcomes and the distinction between disease-specific outcomes and overall health and longevity type outcomes, global health. You know, one of the ways that we look at the adequacy of care is if you're engaged in a value-based care proposition, you accept responsibility for a panel of patients, or you take a PMPM for patients, and you do a sort of an adjustment according to complexity or severity for the amount of resource it will take to render adequate care for either that number of that particular patient, that panel of patients. I think value-based care is likely to be the methodology that fits most comfortably in what we're basically trying to do in primary care. You know, we're talking about disease-specific outcomes, which I think we have to pay attention to diseases, and we will always pay attention to those. But at the end of the day, we're looking at how patients are doing. And if we can actually get to the point where we're taking good care of the patient who says, I don't want to quit smoking, rather I've got end-stage COPD, I'm just trying to stay alive long enough to watch my daughter graduate from law school. So get off of me about that. And we don't get dinged for quality decrements in our quality because we're responding to and listening to the patient's values. I think it's important that we continue to adjust our complexity scores and our patient-centered scores so that that kind of value gets recognized. I have a feeling that's not quite what the questioner meant by this question.
Right, an interesting juxtaposition in language between value and values.
Yeah, I'll just add, Howard, if I can, that,
Thank you.
Thinking about value-based care for depression has really been a driver of the uptake of the collaborative care model. First, as organizations wanted to become patient-centered medical homes, and then as a lot of states have moved into Medicaid transformation, they're really looking for models that can improve outcomes, as Frank described. But the question, it's a terrific question about what about complex patients, and you're not just treating depression, you're treating depression with multiple conditions. And I think, I don't have a great answer for it either, but I think anecdotally, one of the strategies we have in engaging primary care providers to integrate care is talking about the impact of behavioral health disorders on medical outcomes. And with people, we've seen in our diabetes care teams that people that providers really thought would never improve their diabetes disease control have gotten better with treatment of behavioral health conditions, including substance use disorders. And it's like this epiphany when the provider sees what Sarah's describing, people can get better. And so I think that is really a way of engaging providers and clinics around integrating care for these disorders.
Thanks, Lydia. I'm not sure we have to be viewing value and values as mutually exclusive in our thinking, and I'm also not sure that we have to choose one or the other of disorder-specific outcomes being successful and also being attentive to what people want from the interaction. I think it's possible to do both. Colleen, you have another question for us?
Yeah, I'm going to pull 3 question threads together that get at the question of sort of what is essential when we think about integrating behavioral health in primary care. So one question relates to the role of peer specialists. A second question relates to the role of integrating harm reduction. And a third question is, and I'll read this directly, what about methadone? How can we ensure that patients who choose methadone are receiving collaborative primary care?
Great.
And, maybe Sarah and Rich.
Only you could see some clear theme there.
I'm happy to start with that one. Others can jump in.
Great.
Thank you all for those questions. I think the role of peers, harm reduction, and methadone are incredibly important topics. Peers, I think, are invaluable. For us, we think of them as essential non-clinical members of our care team. So, they're not clinicians. The role of a recovery coach is intentionally very separate from a clinical role. But the ability to provide that sort of shared lived experience and support in addressing barriers to engaging with whatever goals the person have, and having it be really person-directed and person-centered, I think has been just invaluable for us. And talk about sort of value-based care. Actually, maybe two of our coaches are paid for by insurance companies because of, I think, some belief that there's value here, that these kind of non-reimbursable costs are actually incredibly important when you think about the complex landscapes that patients are navigating. In terms of harm reduction, I think harm reduction has to be a part of everything we do. It certainly is for other chronic conditions. And for some reason with addiction, we think of it as somehow juxtaposed with treatment, as if it's treatment on the one hand and harm reduction on the other. Those two things are not mutually exclusive. In fact, good treatment, harm reduction are one and the same. And the goal is really not letting perfect be the enemy of the good, would be one way of thinking of it. But most importantly, respecting the dignity, the autonomy, the humanity of people who use drugs, and letting them guide us in what their goals are. And that recognizing many people want to still use drugs, and that there are ways of using safer, and that reducing negative consequences is our primary goal. And harm reduction is not simply a bridge to treatment. I think too often we talk about it that way, as if the goal here is just to keep people alive until they get to treatment. That's not the goal. The goal is helping people live their best life and their best health in whatever way that means to them. And so there's obviously many concrete harm reduction interventions we can do in healthcare settings, like naloxone distribution, syringe prescription, advocating for syringe service programs, safer injection education, hepatitis vaccinations. And then obviously there's things like safe consumption spaces that we don't yet have in the US. Methadone is a great point. So, our best evidence treatment for opioid use disorder, incredibly effective and yet incredibly regulated. And this sort of a great example of how a system can often be more program-centered than patient-centered. I think there are many patients that would benefit from methadone treatment if it were offered in a setting in which they wanted to access it. And the fact that the only option for methadone is through opioid treatment programs keeps it inaccessible to a lot of people. So I would hope that we could modernize our opioid use disorder treatment system and be able to offer the right treatment for the right person in the setting that they choose, which is sort of the theme that we're talking about here, that patients should be able to get care where they want to get care and where they feel comfortable, and with a provider team that they feel comfortable with. And they shouldn't be told that they have to go to this separate and unequal system or to a certain site only and have a piece of their care carved away. And I think just generally this siloing of sort of behavioral health on the one hand and medical care on the other hand, or even within behavioral health, that there's mental health or psychiatric illness and then there's addiction. Like, our patients don't experience these things as separate. They are a human being who's having lots of complicated and very interwoven issues. And to Lydia's point, I have a patient who we can track his A1C. He has type 1 diabetes based on his housing status and whether or not he was having chaotic drug use at the time. And his A1C just tracks along. You don't need to look at toxicology testing or anything else. All of his diseases, experiences are interwoven, as well as the psychosocial stressors that people are under. So anyway, thank you for those questions.
I'm glad you were here to tie those together. Who is it? Rich, did you have something to add there?
Sorry, just a very quick emphasis comment on methadone. In the way that the system is currently set up, there are ways to use the integrated care model to try to communicate, but you have to make a huge effort to try to communicate with opioid treatment programs. Now, it's worth doing, because then that's the way that you can integrate the care and have the primary care system be aware of what's being prescribed, be aware of the doses, sign the releases. And it's a lot of work to do it, but you can do it. But the better answer, I think, is what Sarah was hinting at, which we all hope to have, which is the way to integrate methadone care into treatment into primary care would be to integrate it into primary care, like have it be prescribed by primary care clinicians in primary care settings, like it is in many other parts of the world.
Yeah. Bingo.
And by the way, we should not, it should be clear to folks that that's not currently allowed in the United States, in case anybody gets the wrong idea. So.
Yeah, no, thanks for clarifying.
So here, next question. So this gets to the issue of how can primary care practices build out behavioral health capacity? So like a make or buy kind of question. And the specific question is, how can specialty behavioral health practices reach out to and build partnerships with primary care practices? So how can this work begin?
That's challenging.
That's a great question. And I feel like we're living that in Washington State as we're sort of ending our 5-year Medicaid transformation waiver. And that's been part of, as the regional accountable communities of health focus on integrating care, there's been a lot of support and training around, supporting behavioral health agencies to do this. And how will they be financially incentivized and otherwise incentivized? It's challenging outside of that kind of structure and external support to do it. But I think, again, in small communities, thinking about your referral patterns, who are you working closely with, who do you share a lot of patients with, and kind of looking at these models and trying to make a financial case for it. But it really is, I think it takes a leadership vision to say, we can do this, this is what it would look like, this is the staffing, modeling it out, and then making a pitch to a primary care organization. So
your department has done that throughout the Pacific Northwest and Alaska, if I'm not mistaken.
Well, there's a difference between the university providing consultation services and contracting versus a specialty community mental health agency, which is, has very, is financially not in the best situation to begin with, trying to innovate. I mean, I think that's been a real challenge for or individual organizations. But yes, departments of psychiatry, of course, are a great resource everywhere in the world to medical settings.
Anybody have anything else before we go? Frank, go ahead.
Lydia, I love your comment. I watch good faith efforts in the Pacific Northwest to link behavioral resources to primary care. It's hard. We've got a good example. Perry Dickinson has quite a record of success in Colorado doing that. That's just with existing clinicians who are community-based and creating linkages for them. But one of the things that I think we ought to actually emphasize more is the value of, we have in my department of family medicine, we have an APA psychology internship training primary care clinicians who happen to be psychologists. We have rotations for the psychiatry residency program in primary care. It's not CL, it's integrated primary psychiatric care. We have an addiction medicine fellowship in family medicine. I don't think there's any reason why all of the primary care programs in the US couldn't incorporate as a matter of routine, just like we have sports medicine fellowships, geriatrics fellowships, as a routine part of our training, preparing an integrated primary care behavioral workforce. People who train together, practice together. And I think it ought to be part of our mission.
Great. That's a thumbs up from Rich Seitz. For those of you who have trouble seeing the little image that, like I have on my screen. All right, Co-Chair Colleen Berry, what's the next question?
The next question has to do with stigma. So what you folks have been talking about is models that would provide essential care that aren't widespread. How much does stigma explain our lack of ability to get the stuff out into routine practice?
Great, and I'll add to stigma discrimination. They're evil twins.
I'll make a quick comment about stigma. I think it's a huge reason. We have federal agencies that deal separately with substance use and mental health compared to the rest of health. So it's really just reflects society, right, at a very high level and at a structural level. And I think the beauty of some of the ideas of integrating these into primary care is it's almost a way to be able to push back on that and make it clear that no, this really is part of health and healthcare, part of primary care service delivery. And I think that'll have an effect on the rest of society, hopefully. It's hard to change people. I mean, it's just one way to help change the way folks view these conditions.
I
And
think
the way providers view them too, right? I mean, it gets back to what you were describing earlier, that that there's stigma even when you go into go for care from the provider, and it can be unconscious, it can be very subtle, it can not be very subtle, and just so thinking about integrated care models, but also gets back to training of our workforce about how to treat these conditions.
Well, I don't know if it's stigma and discrimination, but it certainly is separateness. I think the newest frontier is not recognizing the fundamental nature of behavioral health to overall health, but not making such a strict boundary between the health sphere and the broader societal social welfare sphere. That is something that I think behavioral health handled earlier and better than general medicine. Concern about housing and other issues. But if we're going to be able to address the problems of structural racism, for example, we're going to have to broaden our view of what our responsibility, at least our shared responsibility, is. Colleen, another one?
Yeah, this is such a cool question. I'm going to read it directly. Can presenters speak to the concept of flattening hierarchies in the treatment team as it relates to improving patient care and employee satisfaction? So can we change the way our teams are operating to achieve better goals?
That's great. We've got 4 doctors to ask this question to. Well, you're all smiling, but nobody's talking.
I will say I'm happy to take that one. I think
go Sarah, go.
We continue to work really hard to do this, and I think it is hard because, like many other structural things, the hierarchy is so deeply embedded in everything we do. All of our care teams have intentionally been interdisciplinary, interprofessional, interdepartmental. So for example, our inpatient consult team has doctors from medicine, doctors from psychiatry, advanced practice nurses from both medicine and psychiatry, social workers, peers, trainees from lots of different types of backgrounds. And we round every single day together in a room, although some people are now on Zoom, but still mostly in a room masked, despite the fact that our list has ballooned to like 60 plus patients. But because I think having multiple perspectives and multiple voices talking about a patient is really, really important, including the voice of people with lived experience who often have the most valuable nuggets of wisdom about some of our patients who are dealing with the most complexity. But I think, the system is set up in a hierarchical way. And so that takes active work literally every day to do that. And it's still imperfect, but I think it's incredibly important. And in a way, it helps us center the patient's voice, right? Because medicine is also hierarchical in how we treat patients, that, again, thinking in the hospital, we're all towering above a person in essentially, a backless bathrobe, lying in bed while everyone looms over them. And there's huge power differentials that are just baked into the way the system works. And to try to neutralize that, to again remind us that this should be about patients guiding and directing care, and that requires equalizing the hierarchy and getting multiple perspectives and multiple voices.
One way that we do it in our primary care outpatient alcohol and drug treatment, and this is embedded in primary care, is to have those who may be lower on the hierarchy actually lead the team. So we have the physicians who are, the physicians have very specific functions to prescribe a medication when appropriate, see the patient, of course, and a psychiatrist may have a specific function. But it's the nurses who manage the care. They manage the care more directly with the patients and really prompt the next steps and make it actually feasible and possible for the rest of the team to be able to do what they need to do, their specific pieces.
All right, thanks. We have really,
Howard, do I have time for one more question, maybe?
you're the
Before
chair.
we transition?
You're the chair of this forum. Of course you have time for one more question.
I'm tempted to make it like a 17-part question because there's
Oh
so
yeah,
many
please
awesome
do that. We've got
questions here.
exactly 30 seconds, Colleen. Go ahead.
I won't. But I want to say we have over 500 participants here, and these are extraordinary questions. My hat is off to all of you, and I really do wish we had time to answer every single one of them. And just to answer one, that this session will be recorded. So for those of you that are not able to participate for the full time today, the last question is actually a really interesting one. The participant asks about, so the chronic care model is focused, obviously from the name, on chronic care, but what about sort of this integrated care model concept for more acute care situations, so many of which we're seeing right now in the context of the devastation of the COVID pandemic, job loss, death in the family? How can these essential components of care and integration sort of help us do a better job supporting people in our communities right now?
Great question. Frank, you'll get the answer to this question.
I think here's one way to classify the work that occurs in primary care. The primary care team concerns itself with addressing the personal care plan for a patient in partnership with that patient. And the category of problems that arise there can sort of conveniently be put into chronic problems, chronic illnesses, chronic diseases, acute problems, prevention, and other. There's a miscellaneous, messy other category. But acute problems arise all the time. The primary care team, which is integrated, consisting in our case of a behavioral clinician, a clinical pharmacist, a sort of a medical primary care clinician, care manager, and so forth, some others, feels the problem, whether that's acute or chronic, and deploys the member of the team best suited to deal with the most urgent or important to the patient or salient or dangerous problem at hand right there. So this model of care works equally well for acute as compared to chronic problems. It's just a matter of constituting your team so that it is competent to deal with the range of problems that occur in ordinary primary care. No big sweat. I could keep going, but
time is limited.
Colleen would kill me.
Thank you, Frank. Let me thank all of our presenters, Rich Seitz, Sarah Wakeman, Lydia Schwastiak, and Frank DeGree. This is where I wish I had a soundtrack for the thunderous applause that you would normally receive if we were all together in the same room. And we're going to end this session and go to the next, but thank you all for your participation, and thank you to the audience for your questions. We shift now to an implementation session. The moderator for that is Perry Dickinson. You heard Frank refer to him earlier. He's also at the University of Colorado. He's a member of our planning committee, and it's over to you, Perry, for the next session as our moderator.
Thanks, Howard, and thanks to the panelists on the previous session. That was a great discussion and set up our discussion extremely well. I'm honored to moderate this session dealing with the implementation of the essential components of care for depression, alcohol use disorder, and opioid use disorder in primary care settings. We know that primary care practices and clinicians have often struggled to achieve optimal implementation of these essential components of care due to a number of factors, many of which were touched on in the previous sessions. Things like the diversity and complexity of the issues presented by patients in primary care, some systemic disincentives for practices to identify and treat behavioral health issues, workforce and training deficiencies, uneven or absent payment for behavioral health services in primary care, and myriad other factors. We certainly entered this territory in the previous discussion, and in this session, we will further explore models and lessons learned regarding the integration of behavioral health care in primary care settings, key factors that support or impede implementation of essential components of care, approaches to addressing the key barriers to implementation, some of the implementation differences that may exist for various types of practices with different demographics or varying levels of resources or that serve different age groups. And around that last issue, discuss how different approaches may be necessary in caring for children. Our panelists today, if we could go to the next slide. David Keller is the professor and vice chair of clinical strategy and transformation in the Department of Pediatrics at the University of Colorado. Stacy Sterling is a research scientist and co-director of the Center for Addiction and Mental Health Research at Kaiser Permanente, Northern California. Suzanne Snyder is director of behavioral health in the Access Community Health Network in Chicago. And Laura Murray is a senior scientist in the Department of Mental Health of the Johns Hopkins Bloomberg School of Public Health. We'll start off with David Keller. David?
Oh, I hit the video unmute, but not the unmute. Thank you, Perry, for that introduction, and thank you very much for inviting me to join this panel and to ask the question when we're implementing the essential components of care in primary care settings, what about the children? Next slide, please. I was particularly pleased to ask this as a general pediatrician because mental health, because I know and all my fellow pediatricians know, and my fellow family docs and peds practitioners and nurse practitioners and everybody else who takes care of children knows that mental health problems are common among children and youth, but they're a little bit different. ADHD, behavior problems, anxiety, and depression account for almost a third of most pediatric primary care practices visits as a primary diagnosis. And if you dig down into the rest of our visits, you'll find that they are a factor in another third of our visits. Access to treatment varies by age and condition and socioeconomic status. And I found a lovely report that has recently been put out by the Centers for Disease Control that talks about this. You can see in the graphic next to us that depression becomes a major problem as we enter adolescence, but is certainly a problem in the school age years as well. But prior to that, and even more than that, we're seeing anxiety and other behavior disorders within our child population that need to be dealt with. And the most common place that these are dealt with is in primary care. Something on the order of 70% of psychotropic medications that are prescribed for children are prescribed by primary care physicians rather than behavioral health specialists and psychiatrists. So the first line of treatment is usually a primary care practitioner, and it's important for us to acknowledge that going on. Now, when you're devising systems of care, like those that have been described in earlier webinars, it's important to think that these things are different for children. Next slide, please. And I always go back to the Institute of Medicine's report from 2005, the Children's Health, the Nation's Wealth, for the underlying model of this. The key difference is that when caring for children, our goal is to maximize the upward trajectory of children. Children are developing and changing and moving into adulthood. And our job is to make them, to improve their health to the point where they are the most successful adults that they can be. And that involves work in the social environment, biology, physical environment, and behavior, all of which is handled through this kaleidoscope of services and policies that impact children throughout their lives. There are 5 things that you need to think about when you're thinking about services for children, which have been characterized by others as the 5 Ds. And I'm going to put those out there. Development. Children are developing quickly and they change rapidly over time. So child development has to be a factor in thinking about the systems that you're devising. Dependency. children always are in a dependent relationship of some sort, whether it's functional or dysfunctional, but it's always there. The different epidemiology of problems, and particularly the fact that the diagnoses that fit into the adult world don't exactly fit into the child health world in mental health, is really important to consider. Our demographics are different. The young population of the United States in particular is much more diverse than the elders. And we need to make sure we account for that in devising our systems. And dollars flow differently for children. The fundamental difference is that the base of all medical care in the adult world is Medicare. And that has absolutely no impact on us in the child health world. The base of our medical care is Medicaid, which runs a very, very different system. Next slide, please. So let's try to look at behavioral health integration through a 5D lens. How do development, dependency, different epidemiology, demographics, and dollars impact this continuum of behavioral health and physical health integration that's been proposed and put out there? It certainly impacts how we do coordinated care. It can impact how we do co-located care, and it can impact how we do integrated care. And I wanted to use the 3 use cases that were proposed here to talk about how you have to think differently about those systems as you're thinking about opioid abuse, alcohol abuse, and depression in developing systems to manage that. Next slide, please. Now, let's talk about opioid treatment. Opioid treatment in the context of maternal child health has to be and has to involve the issue of mothers who are opioid dependent during pregnancy and may be delivering children who have neonatal abstinence syndrome or are at risk for neonatal abstinence syndrome. How do you develop systems to handle that? Now I put the MOM model that the CMMI recently put out as an example of this kind of care. But I'll say, in addition to that recent funding, and thank you for that, CMMI, there are a number of initiatives around the country that are proposing to develop a coordinated set of care between the maternity and infant care, the behavioral health and primary care, and the opioid use disorder treatment that is required to be able to manage these dyads correctly. Developmental support, it has to include not just the healthcare system, but it also has to include our early intervention system, which is separate but really important to making sure children develop properly. A lot of maternal opioid use exists in the context of complex family systems, and very often our departments of social services are involved. How do we engage them in the team that we're trying to develop? The infant, mother, and family often are dealing with multiple diagnoses, not just opioid use disorder, but mental health disorders and socioeconomic factors that are impacting the way we deliver care. Race is a factor here, as you heard in the earlier webinar, as well as the fact that much opioid abuse happens in rural areas, and we have trouble pulling together the teams we need in those areas. And the payment models for all of this are incredibly complex. There are bundles of care for delivery services in point of fact, but the infant care is often on a fee-for-service basis and completely disconnected from that. And then we go and carve out mental health and substance abuse treatment, making the design of the system really difficult as we move through that. Unfortunately, I'm not proposing solutions to all of this, but I do think we need to take these factors into consideration as we design the systems going forward. And I look forward to seeing what comes out of CMMI's efforts in this area. Next slide, please. What about treating depression? Now, you probably thought I was going to go with adolescents when I said I was going to talk about depression, but actually I'm going to talk about school-age children because I find them to be a much more difficult problem. We don't have great screeners for school-age children, that we often are seeing them in our offices without support, and it can be really challenging to get the support that we need. One of the possible solutions for this recently proposed and funded was the Pediatric Mental Health Care Access Program that HRSA is currently piloting in the states you see listed there. What that does is make a child psychiatry consultant available to primary care physicians who are trying to manage and other practitioners who are trying to manage these complex kids in their offices. They're helping us come up with some developmentally appropriate screeners that we can use, as well as developmentally appropriate therapies and medications that we can use to help manage these kids. A lot of the depression in that age group is comorbid with anxiety and is trauma informed. So we need trauma informed therapy to be able to do that. And that recognizes both the dependent relationship that the children are in within their families, but within the public school systems as well. I already mentioned that anxiety was a comorbid condition, but we also find there's an awful lot of bullying and other behaviors that can be associated with depression in this age group. We have to deal with that as well. The demographics I mentioned, the lack of child psychiatrists, and the payment models, again, can be difficult, especially how to support this kind of program. A number of states have built line items into their state budgets to support this program. People are using Medicaid and grants to do it. We need to figure out how to do this better and how to make this sort of support for primary care reach across the country. Next slide, please. And then finally, I'm going to talk a little bit about adolescent substance abuse with an integrated team and how different teams have tried to integrate SBIRT into their practice. SBIRT, as you know, is the Screening, Brief Intervention, and Referral to Treatment program. It has been developed and modified to be appropriate for adolescents, and yet we still find it not being widely used around the country in practice. Why is that? Well, first, the issue of confidentiality is tricky. It's different in each state, and a practice has to understand it and be able to integrate that into the way they practice in order for it to be to work. Second is the relationship of the adolescent to his family is complicated, and the stigma of substance abuse is hard. And how do we navigate that need for family engagement in helping to manage a substance abuse problem with an adolescent with their developing and rapidly changing need for independence is something that requires additional training and thought as you build your teams for being able to deal with adolescents in your practice. The epidemiology is a little bit different. Binge use is much more of a defining factor of substance abuse problems in adolescents as opposed to the chronic use, which is often the case in adults. And you have to build your screener with that in mind, and you have to build your program with that in mind. The substances vary across the country, alcohol, opioids, methamphetamines, other newer drugs, some of them that I'd never heard of before I started researching this talk. All of that is happening around the country, and you have to be ready for that. And then you need to understand how the dollars are going to work in paying for confidential services, and how do you arrange to be able to work with an adolescent who isn't ready to disclose this with their parents, and yet we can't have the parent discovering by getting a bill. Last slide, please. So I think the final lesson I wanted to leave us all with as we're thinking about these systems is that children are not little adults, and that it's important to look at your systems through the 5 Ds. The picture is actually the building I'm sitting in right now. I have a clinic in about an hour, so I'm sitting in a closed room in the clinic giving this talk. We need to think about child development. We need to think about dependency. We need to think about the different epidemiology. We need to think about the way demographics factor into this, and we need to think about how the dollars accrue. Integration requires a broad team, and we also need to think, how do we make that team work across systems, social service, education, juvenile justice, to really benefit children? I have to close with an inspirational picture from Colorado. Next slide. Because the mountains really help me when I'm trying to wrestle with all of this stuff out here. And I look forward to the questions and thinking with you all about how we can do a better job of making sure that the systems that we build serve all of our population, including the children. Thanks.
Thanks, David. Next, we have Stacy Sterling from Kaiser Permanente, Northern California. Stacy.
Hi, thank you. So I'm going to get really pragmatic here and talk about some of the nuts and bolts of implementing alcohol SBIRT in Kaiser Permanente, Northern California. And we are a large integrated healthcare system with a very diverse membership. Next slide. So our SBIRT approach was really informed by an earlier study conducted by our research group, the ADVISE trial, which was an implementation trial looking at different ways of delivering SBIRT. And the health system adopted the components that we found to be most effective in ADVISE, which was having medical assistants do the screening as part of their screening for alcohol use as part of their regular rooming process, and having the physician deliver brief intervention and refer patients for specialty treatment if needed. This model rolled out in July 2013 to serve all of our adult primary care patients through about 2,500 primary care providers. And since then, we've conducted over 12 million screenings and delivered almost 800,000 brief interventions. Next slide, please. So I'm going to describe some of the factors that we found to be most key to successful implementation, and I'll show you a few examples of how these have been operationalized. Leadership support has been critical. Both the executive medical director and the head of adult primary care in the system recorded videos for our physician trainings, emphasizing the importance of the work and encouraging PCPs to participate, which is really important because alcohol and drugs are rarely at the top of mind for busy providers, and also the message really carried more weight coming from fellow physicians rather than pointy-headed researchers. We involved stakeholders from primary care, addiction medicine, psychiatry, and research throughout the entire process. We used an implementation facilitator, especially at the beginning of the initiative, who provided clinical teams with coaching and technical assistance. We established teams at every medical center consisting of a primary care provider and a chemical dependency clinician counterpart to serve as the resident SBIRT experts for their colleagues. And then embedding SBIRT tools into the EHR was an important part of our strategy, and I'll show you some of those in a second. Next slide, please. So this is an example of a matchmaking email that we use to introduce members of the SBIRT teams at each medical center and encourage collaboration. And we also brought all of the teams together regularly by conference call to share successes and troubleshoot challenges. Next slide, please. This is a screenshot of what the medical assistant sees initially in the EHR as they're rooming the patient and recording their blood pressure and weight and so forth, and it reminds them to ask about alcohol use. Next slide, please. This gives the medical assistant the screening questions, and these are informed by the NIAAA clinician guide, and these include a version of the single item binge drinking question, automatically tailored to the patient's sex and age, and then 2 follow-up questions on weekly drinking quantity and frequency, which are calculated to show weekly consumption. Next slide, please. This best practice alert then presents the provider with the patient's answers and whether the daily, weekly, or both limits were exceeded, and if so, it recommends that they provide a brief intervention. Finally, it provides additional assessment questions for the provider to use if they think that the patient might be at risk of an alcohol use disorder. Next slide, please. So we used a train the trainer model, and this was based on work done by Dr. Sates, who you heard from, and Dr. Dan Alford. And the alcohol champions, the physicians at each medical center, trained their fellow PCPs on brief intervention and referral, and nurse managers trained medical assistants on the screening process. And the training really emphasizes normalizing discussions about alcohol use as part of overall health and well-being, because we found, as we were discussing before, many of the clinicians were anxious about having these discussions with patients, and these conversations are fraught with stigma. Screening and brief intervention performance feedback is provided to clinicians on a regular basis. Next slide. In the provider trainings, we provide very concrete scripts that providers can use or adapt to discuss alcohol use. And these really emphasize tying use to patients presenting health problems. So whether it's hypertension or sleep problems or depression, to shift the emphasis from alcohol use per se in isolation to use as part of their overall health and well-being. Next slide. In the medical assistant trainings, we really tried to acknowledge how those conversations can be awkward and address head-on the concerns that the MAs might have, like patients getting angry or refusing to answer. And we tried to give them specific ways to deal with those situations. Next slide. We practiced skills a lot with the medical assistants, for example, having them practice asking the screening questions correctly, because we know from the literature that how questions are asked can really affect people's willingness to disclose alcohol use and the accuracy and validity of their answers. Next slide, sorry. We developed standard drink size posters, which are displayed in every primary care exam room, which help to get everyone on the same page about consumption amounts for these conversations. Next slide. And finally, here's some examples of the performance feedback reports that are sent to managers and physician leaders to help create a little healthy competition and spur performance. So this one shows brief intervention performance by medical center compared to all of the medical centers across the region. Next slide. This one is sent to the chief at each medical center, and it shows brief intervention rates by individual provider and is often presented unblinded during staff meetings, and the alcohol champions can use these to talk to low and high performers about, how they're doing. Next slide. And finally, this is the medical assistant report card that the manager reviews each month with the MA and includes alcohol screening rates, and so they can talk about how they're doing. So these are just a few of the things that we have done to facilitate successful implementation in our SBIRT program. Thank you.
Thank you, Stacy. And next up is Suzanne Snyder, Director of Behavioral Health in the Access Community Health Network in Chicago.
Good afternoon, and thank you for the opportunity to share some key aspects of behavioral health integration and our journey toward that at Access Community Health Network. And I'm going to do this from a clinician's feet on the ground point of view. I was one of the first 2 LCSWs to ever come to Access to provide behavioral health care. Next slide, please. As an FQHC, we have 35 health centers throughout the Chicagoland area, and we've been on the journey toward behavioral health integration for some 20 years. And it started with behavioral health clinicians joining our Ryan White HIV wraparound care teams. And this is important because it means from the beginning, we have had collaboration in our care in our DNA. Next slide. Key to our integrated model is patient engagement, population health management, looking at social determinants of health, and behavioral health needs of our patients. From the integrated behavioral health point of view, our services include universal screenings for depression and SBIRT, care coordination, integrated medicated assisted treatment, and psychiatry and therapy services. Next slide, please. We know that behavioral health in primary care promotes triple aim goals, but it's the triple aim's third goal of improving the patient's experience that most informs my advocacy for integration. There is a long history of stigma, lack of health parity, and siloing mental health and substance use care. I believe that integrated behavioral health care at its best provides patients an alternative experience, a healthcare experience that assures the patient that every door is the right door to begin to holistically address their healthcare needs. Next slide, please. I acknowledge that every door is the right door is an aspirational statement. striving to make this statement a patient reality is a guiding principle of our integration work at Access, because many patients come to primary care first as the door that they will come through when seeking mental health or substance use answers, even when the identified reason for their visit is something different. So as primary care providers, we must address our patients' mental health and substance use concerns, including breaking down environmental barriers and attending to all social determinant issues of care, as well as helping our patients move toward positive health behavior changes. Next slide, please. So when I think about our integration journey at Access, there are 4 components that come top of mind to me. And first is a trauma-informed, patient-centered collaborative care approach. We know and we've learned through mistakes that this is foundational. Several years ago, we launched an all systems rollout of universal depression screening without sufficient input or training across the organization or preparation for our patients. We learned a lot from that. And having learned from that, when we launched universal expert screening, we used a much more trauma-informed approach for all. We started actually by launching our anti-stigma campaign that we call We Ask Because We Care. And we use this messaging consistently in our exam rooms and in much of our literature to normalize screening for our patients and, quite frankly, for our care teams. When we launched Esport, we also carefully defined roles and workflows and launched each health center individually, revisiting teams weekly and making adjustments along the way. No surprise, the provider response was much more positive. They felt much more supported because in addition, we gave providers and care coordinators training in motivational interviewing and patient-centered educational tools. As we grow our medicated assisted treatment services, we are also guided by patient-centered collaborative principles. We work to meet patients where they are, and what that means to us is that we continue to grow our MAT services. We have MAT services at 14 of our health centers, and we plan to continue to grow because we believe that our patients should receive care in their own communities by providers and care teams familiar to them. So when we open a new site for MAT care, we train the entire health center team on what it means to meet a patient where they are. This means focusing on harm reduction, overdose prevention, addressing our implicit biases, and the importance of providing patients access to treatment at the point of care and at the time of care when they are ready. We also know that input across disciplines is important when adopting evidence-based practice tools and interventions. And for example, we use the PHQ for depression management. Developing documentation and workflows and updating metrics is led by behavioral health, but it is a shared responsibility by chronic disease and maternal and child health as well. We have learned to leverage our integrated electronic health record, especially using notes with purportable fields in areas such as stages of change, target symptoms, best practice interventions, and most importantly, tying them to quality metrics that are transparent to all. Lastly, I want to say that ongoing adjustments are to be expected. Integration is ever evolving and clinical needs change, sometimes quickly. In response to COVID-19, some of our providers asked that we change our adult depression screening workflow to make the PHQ-4 as well as our standard PHQ-2 available as an option for initial screening. More patients are presenting with symptoms of anxiety as well as depression, and the PHQ-4 facilitates initial screening for both. Because of the shared responsibility for depression management across disciplines, we were able to make this change easily and see it as an organization as a first step to addressing the mental health needs that COVID-19 has laid bare and exacerbated. Next slide, please. Equally important to understanding the components of integrated care, we have learned over the years that we have to accept that there are challenges that are persistent and that should be anticipated and addressed whenever taking new steps in integration. So I'd just like to share those with you. Many have already been mentioned today, but we try very hard that whenever we're starting something new to really check through these and communicate throughout our organization how we will be working to address them. Provider and resource shortages along the continuum are ever present. Patient health information sharing should be always anticipated and part of the workflow so that patient care along the continuum is smooth. We advocate for reimbursement systems that more fully support integration. We are always looking for ways to bridge differences in care paradigms so that there's shared language between traditional behavioral health and medical services. And we work hard to work with our providers and care teams about time and timing challenges. This is a key issue to success and to fidelity to any new intervention that we will put into place. And last, I don't want to forget the importance of supporting our care teams and providers as they do more work in the integrated field. Many times this means that they are exposed to new trauma loads and new trauma experiences of their patients that they may not have been exposed to before. So we work really hard to help manage that vicarious trauma load that our care teams are facing. I want to thank you today for this opportunity to share these challenges and these key components as a clinician that's walked the journey of integration since I won't say what year, but early in this century. And it's a pleasure to be with you today. And I look forward to sharing in the dialogue.
Thank you, Suzanne. Before we move to our next presenter, I just want to remind everyone that we will have time for a question and answer session at the end of the, after the panelist discussion as well. And so please start thinking of questions and entering it into the Q&A box so that we can have a robust discussion of some of your questions at the end. So next and the final of the panelists is Laura Murray, who is in the Department of Mental Health of Johns Hopkins Bloomberg School of Public Health. Laura.
Great, thanks, Perry. What a pleasure to be here with all of you, and we've heard so much great information today. So I'm going to be talking about breaking down silos to improve integrated care, specifically about the common elements treatment approach, something that Sarah and Lydia already talked about with silos. Next slide, please. Great. So just setting the stage for integrated care, one of the truths that's really important, and again has been mentioned by others, is to recognize that as humans, we present with comorbidity. And so for mental, emotional, behavioral health, comorbidity is really the norm. As clinicians, we rarely ever see or hear of an individual with just depression or just trauma or just substance use. Next slide, please. So despite this comorbidity, the current approach to providing services is the siloed approach. Now, many of us are familiar with this. Silos exist in most organizations, areas of study, businesses. And in mental health, it's very common to teach providers different types of evidence-based therapies that focus on one area. So for example, someone would learn an evidence-based protocol for treating depression, or a protocol for treating substance use. Next slide, please. Great, so with the siloed approach, mental and behavioral health specialists are needed to train in an estimated 8 to 10 different evidence-based treatments in order to serve the comorbidities and a population. So even with this, we're coming in with a major flow problem for integrated care, not treating the whole person, but instead zeroing in on only one problem, often leading to missed referrals or long ongoing sequential care. This is challenging at best, often impossible, and most certainly costly and unsustainable. Next slide, please. So one solution for silo busting within our field of behavioral, emotional, and mental health is the common elements treatment approach. And we work primarily in low income settings. And it's built as a modular, multi-problem program. So it doesn't address just one problem. It addresses multiple problems, not just two, but a very wide range. So depression, violence, trauma, aggression, risky behaviors, substance use, etc. So with one approach, we're able to address multiple different problem areas and customize these to the individual, making it a de-siloed approach, which is much more scalable and integrated. So just to take a closer look at CETA, next slide, please. So we don't conceptualize CETA as a new treatment. It's sort of a different approach, breaking down some of those silos. So what you see here is a range of elements that are very evidence-based. They have a wealth of data behind them. And we teach providers and counselors to put these elements together in different ways to address whatever comorbid problems individuals might present with. So given its design, it also has the flexibility to move into stepped care models where someone might need only one or two elements, for example. Oftentimes we pull out safety for suicide or cognitive coping or retraining the brain to address behavioral challenges with medication regimens and whatnot. Next slide, please. So this is a graph just from a number of studies in Iraq showing that CETA outperformed focal treatments. Here we looked at cognitive processing therapy, which tends to focus on depression, and then behavioral activation, or sorry, trauma, and then behavioral activation treatment, which tends to focus more on depression. And what we saw here is that a transdiagnostic multi-problem approach really is more effective. And we're seeing very similar results with studies in the United States looking at transdiagnostic models addressing comorbidity. So not much of a surprise when we treat the whole individual, which others on the panel have mentioned, and we address all their problems, we can usually be more effective. Next slide, please. I just wanted to quickly comment on a recent study we did with CETA in Zambia, where we looked at interpersonal violence and alcohol use. This was just recently published in PLOS Medicine. And we're particularly excited about this because in mental health, many times you're either trained to do mental health or you're trained to do substance use. And so what we did is combined these in the CETA protocol. And what you see here is great effect sizes for alcohol use. And what we're really excited about is that 12-month and even at the 24-month, we are able to maintain that reduction, which is very exciting. Next slide, please. So what is the takeaway of some of this research and why we are sort of moving in this direction? That CETA is really an effective treatment, and it's effective for many different mental health problems, such as violence, alcohol abuse, depression, trauma, externalizing and internalizing problems in kids. We actually train in our work lay providers in low resource countries, and we know that this is acceptable and feasible and still remains very effective. Next slide, please. Great. So just to end with talking a little bit about policies for integrated care that can help from the clinical side. We still have a very deeply embedded siloed care approach in our training, in our care settings, and in funding. And until we de-silo these, we are going to have a lot of the challenges ongoing. And de-siloing is a very difficult process. Businesses and organizations have a lot of trouble with this. So really looking at how can we do that? The other thing is comorbidity. There's still a tendency to only mention depression or still sort of look at only substance use. And so even in our trainings, we have to try to move that space away from treating just one thing to really looking to the person as a whole. The other thing we talk about is re-examining licensing and reimbursement. We heard the importance of evidence-based care earlier. This is not mandated, many times not used. Many times people leave their programs without actually being trained in any evidence-based treatments and licensed and sort of, not able to use them. So what that means is if someone is sort of on a team, one of these integrated teams, and they're only trained to treat depression or only trained as a substance use counselor, that's a huge loss. And then we get into a lot of missed referrals and long sequential cares. Next slide. And that's it. Thank you so much.
Thanks, Laura, and thanks to all the panelists. If the panelists would all go ahead and get on video, start your cameras, so we'll have you each up. And so what we're going to do now is have a panel discussion of several questions for a few minutes, and then I'll remind everyone that we do have time for questions and answers after this part of the session that Colleen will sort through and kind of help us address to the panel. I'm going to start off kind of across the board, but I'll direct, all these questions will be kind of for everyone, but I'll direct it first to particular people. The first one is kind of what types of team members are necessary to implement the integrated services that you mentioned in your presentations, and what sort of training do the behavioral health professionals need to adapt to their roles in primary care practices? Suzanne, I'm going to start with you around that because you've done fairly extensive work in this area.
I think key is the behavioral health clinicians and what we call primary care providers. But even more key is our care coordinators who are, some are RNs and some are LCPCs or LCSWs. And also our medical assistants and what we call at our sites community health specialists. Sometimes we call them patient navigators, but folks that can become specialists in one area, oftentimes with lived experience as well. But they're able to do some of the educating and some of the taking care of the ongoing checking in with patients and outreaching to patients. So to us, those are some really key folks. And then I want to say that administration from senior leadership down is extremely important, as well as quality folks and the folks that do your data analytics and all those people understanding that this is where you're headed and that you understand that behavioral health is primary care. For training for behavioral health consultants, I would say it's really important that they have an interest and a dedication to learning about chronic disease processes, diabetes, hypertension, asthma, chronic pain. So they don't have to come to us knowing that, but they have to know that there's going to be a learning curve and they're expected to understand that. And then I think really being able to understand how to engage both care teams and patients and families, and having in their toolkit some very, a variety of evidence-based practices that they are just familiar with, because they don't know when they're going in a room what might be the need for that patient. And so maybe they're even, doing some mindfulness, or they're doing some breathing or some cognitive disputation. So a lot of those kinds of skills. And then lastly, I would say for our health centers and our system, we really focus on being trauma informed and taking care of our care teams, because so much of the work we do, whether it's traditionally seen as primary care work or traditionally seen as behavioral health work, so much of what our patients' health outcomes are based on is issues of trauma. And so a readiness to learn and to grow and understand trauma, both at a structural level and at an individual level.
Great.
That's a lot.
So Perry, if I can weigh in a little from a child health standpoint, and I apologize if there's noise. I'm actually in clinic now, but I've secreted myself in one of the exam rooms. But patients will start coming at some point. I think everything that Suzanne said is correct, but I also don't want to leave with the impression that you can't do it without that much of an extensive team. I've worked in environments where I had one part-time LICSW working with me, the medical assistants and the nurses that I had, and the nurse practitioners that I had, and we actually built quite an effective team with her being able to help train, cross-train folks who often I don't think our medical assistants, for example, thought of themselves as behavioral health providers. But by the time we were through with them, they were providing the essential elements of behavioral health care. They didn't call it that. We didn't bill for it, but we could work with them to incorporate that into their daily routines. The other thing that this, I think, speaks to is the need to incorporate this sort of training into our training programs more broadly. And I'm fortunate here at the Children's Hospital, we've actually got a one-year fellowship, post PhD fellowship for in integrated behavioral health for newly trained psychologists who learn how to work in a primary care model. And what they tell us that they need to learn is what I would call preventive behavioral health care. Whereas a lot of their training is about how do I deal with this diagnosis, we actually train them in how do you help people avoid getting to the point of getting to the diagnosis? How do you work with kids who are having minor sleep problems so they don't become major anxiety disorders and things like that? And I think, again, in the child health age group, that's one of the possibilities is to really expand the definition of mental health care to include the kind of preventive care that we've built into the child health spectrum of care, but is not always considered part of their purview because in most cases they get paid to take care of people who are in trouble, not prevent people from getting into trouble.
I would just add that along those lines, we've had great luck with clinical health educators. So working at that sort of prevention, mild to moderate condition spectrum, and they are really trained and oriented that way and have been very effective.
So going to David's comments, how do you see these integration models differing across different types of practices, across practice sizes and different demographics? Laura, around CETA, that you just presented, you've worked predominantly with international practices, but also I'm interested in how you see this applying to different types of practices and kind of how they would implement it.
Yeah, and we've actually rolled this out in Washington State and working now with underserved communities in Chicago area, and there's a lot of other transdiagnostic models that are being studied in the United States, as I mentioned before. And what's nice is that one of the challenges with integrated care, and I worked on pediatric floors for a long time, so I really enjoyed the first four presenters talking about more sort of a medical model and the challenges coming out of school as a clinician, and certainly social workers also. You get trained to focus in on just one problem, and then you have someone on your team who really can only help in one area. And something that we've all mentioned too with sort of the kids versus adults, that's the other big silo, is we come out of our behavioral and mental health training where we only know how to treat either kids or adults. And so again, then you need your integrated care team to be so much larger. So how we see it is if someone can be trained in one approach to actually figure out which elements and how much of each element they need, each individualized care, and use the same principles that I think Lydia was commenting on in the first section, on really making sure that they're evidence-based, but also we use measurement-based care to see what are we tackling, what problems have we succeeded on, what's not working, do we need a shift?
Other comments from the team? Okay. So Stacy, you have done a lot of work around supporting practices in implementing SBIRT, and I was impressed by the array of different things that you kind of included in the model, the implementation model. Again, I'd say as you're working with different types of practices, different practice sizes, different demographics, are there any key lessons learned in terms of what's most effective with different types of practices or anything of that nature?
Well, You know, I can really only speak to the kinds of large practices in an integrated system that we have. But I would say that I think that making it as easy as possible and as seamless as possible. So the things that I talked about, you know, embedding tools in the EHR, providing really specific scripts for providers or for medical assistants, things like that, to sort of take it, you know, these asking clinicians, whichever clinicians, to do these things can be very fraught and sounds very scary, and they think that, oh boy, I'm going to have to talk to every single one of my patients about alcohol and do a big brief intervention and learn how to be a motivational interviewing expert. And so if you can take those things away and make it clear that, you know, you're probably only going to have to talk to 10%, if that, of your patients, and here are some really concrete things that you can say, and here are the questions. And so just making it as easy as possible and taking away some of that fear. I think there was much more fear before we implemented than after we actually started doing it, and people realized, wow, this is only going to come up in every, you know, every 10th patient, and those are the patients who take up a lot of time anyway, have a lot of chronic conditions that are probably tied to their alcohol use, and in the long run, this is going to save time and help patients to feel better, to function better, help me in my practice. So, yeah.
I would add to what Stacy's saying. I think one of the turning points for us with ESPER is because we use CHSs oftentimes, our community health specialists, to do the brief interventions. We really worked hard on making sure that our progress note with them was very focused and had a lot of reportable elements such as stages of change, and also actual tools that they use, so we can see if they are using those tools, and it has helped with our providers who come behind them, because then they're building on whatever the CHS did. And there's that time and timing issue again for a provider. If they know that they're going to open that CHS note up and right away it's going to say, what did the patient want to do and where do they see the stage of change? And it's a motivational interviewing language, but very simple, very to the point, then they also begin to develop smart phrases in their notes, and that communication starts to happen through the EHR, and that's always really exciting to me when I see that happen. And I don't know if that addresses special clinics, but I do think that it addresses how do you get that adoption. And the other piece I would say is we use piloting a lot at Access, you know, either geographic piloting or piloting with a small sector of, you know, a population, so that people are not overwhelmed, and then we learn what does and doesn't work. And sometimes that's hard because the environmental pressures to do something sometimes can be really strong, but we realize that it's a mistake when you just try to do something all across the board too quickly.
Yeah, Perry, if I can, my practice is part of an integrated care network of independent practices. So it's interesting, about half of us are on the same EHR and about half of us are on different EHRs. And a lot of the tools in the EHRs, of course, are developed here at our clinic, which is linked to the hospital most closely. And it's always interesting to me. So I think that the point that having lots of tools available is really useful, but it's really interesting to me watching how different practices adopt different parts of the tools, and having a set of practice facilitators, of folks who can help the practice look through that list, figure out what works for them and what doesn't, and how they want to go, helping them to find their own way to integration is really important piece of what we're doing, and is hard. And I think it's going to become harder as there's more increasing practice consolidation around the country, but also that leads to sometimes I think a loss of some of the interesting things you can learn from watching these practices being implemented at different kinds of environments and different kinds of practice.
Yeah, in my experience, I've worked on several large-scale sort of projects in helping practices implement a variety of behavioral health integration sort of services, et cetera. And some of the technological barriers here, particularly when you're working across different institutions, it's simpler when you have one network of practices that you're working with, but as you start translating it out to sometimes primary care clinicians are in one system on one EHR, and behavioral health professionals who have their own, kind of very modified, different version of a record keeping system, and the two not talking to each other, it can be a major issue. Along with any of the tools that we kind of bring to the overall mix, then helping the practices to implement those within their electronic health record or within their workflow. David, you mentioned practice facilitators. I'll direct this to you because you've been part of fairly major behavioral integration and practice transformation sort of projects statewide across 3 states now across your career. What are some of the key lessons you learned you've kind of found about how you can support practices in doing this work?
Well, I think the most important one I kind of already said, which is you have to have facilitators who meet the practices where they are and walk in. It's a lot like working with folks with mental illness and substance abuse problems. You have to walk in a non-judgmental way and listen really hard as to both where the practice is and what are the practice's dreams, if you will. I think that's one element. Another element that I've always found really helpful is if the facilitator can help them incorporate the voice of the patient into what they're doing. A lot of providers that I've worked with will say they don't want to tackle it. My patients don't want it. If you can get a few patients, or in my case, a few mothers of children into the room, you'll discover pretty quickly that they want it, and you should want to figure out how to incorporate into that practice. It also moves you to that space where the patient voice becomes formative in helping to design the systems, and I think we get better outcomes when we do that anyway. But if that can be so I think those 2 things are really useful, and then finally I think it's really important to be cognizant of the multiple, particularly on primary care physicians. We heard about this in the previous panel, the multiple different pressures that are being put on primary care docs these days and primary care nurse practitioners and PAs. I don't want to be exclusive. Anyone in primary care is extraordinary. We're being asked to do lots of things in lots of areas all at the same time. And then they gave us COVID on top of that. Hence the face shield that I'm wearing on top of my head right now. And we're all suffering from change fatigue. So you have to have some skill at working with your practices on managing that change fatigue that's going to happen as you move through these different processes. And we did, Perry, thank you. I did participate in one of the things that Perry led, and I can tell you he's really cognizant of all of these things as we went through that initiative.
So any other comments from any of the other panelists around that, just how to support practices in doing this?
Yeah, can I just add in, we, in our ESPERT effort, obviously medical assistants were really the linchpin in terms of screening. And, they often don't get the kind of recognition or respect necessarily that other clinicians in clinic do. And so the practice facilitator really worked closely with them, went to huddles all over our region, did a lot of in-person and also, by phone coaching. And we really tried to tap into their inherent desire and they're feeling that they are the frontline people out there representing their patients. They want to help patients, and how this fit into their goals and desires to improve patients' health and well-being. So, really focusing on those folks more so necessarily than the physicians who were providing the brief interventions.
Thanks, Stacy. That harks back to one of the questions for the earlier panel around, how to deal with hierarchy in practices. And I think one of the major interventions that, as I look at supporting practices to do this work, is kind of working hard to at least try to level out some of that hierarchy. And I have found oftentimes in practices that have been really recalcitrant, in terms of opposing change. If you could at least get a little bit of endorsement on the leadership level, but then really get the MAs or other behavioral health professionals in the practice, other folks who really, if anything, are a little bit closer to the patient perspectives and all, and really get it, they can move the practice forward. And maybe, having leadership at that level is probably as important as having leadership at the clinician level as well. So I really appreciate that comment in the earlier question around that.
Could I make a quick comment on that, Perry?
Yes.
I also really liked that topic, and I think one of the things that we see globally, but certainly in hospitals and clinics too, with that hierarchy is, in the business world, a lot of people talk about psychological safety and what that means in the context of an organizational culture and climate. And hospitals and clinics are some of the worst as far as creating that, because there's a divide with how many letters you have after your name and maybe how old you are or how long you've been around. And I think it's time for us to sort of look at ourselves in that way too, where businesses have been sort of moving on that trajectory. We haven't seen that flow yet into healthcare. And I feel like it's time to maybe start thinking about, do people really feel that they can speak up? Because in most of the places I've seen and people I've talked to, that is not the case yet. So that might be something we can do for, to do better to help our patient care get better.
Thanks. Any other comments? So Laura, you mentioned at the end of your presentation, you really started getting into some policy sorts of things that were limiting our ability to implement change in practices. I'd really like for all of the panel members to think about what recommendations you would have for policymakers that are looking to encourage implementation of integrated models of care. How do they make changes in policy that would help us in overcoming some of the barriers that each of you outlined in your presentations? I'll start with you because you kind of hit on that with that last slide.
Sure. So I'm actually a clinical psychologist by training, and most of my trainings done in the United States are with social workers. And then of course, globally, we have lay providers. But what I see in the United States is that, you're either trained as a substance use addiction specialist, or you're trained in these silos of mental health care. And when we come out as mental health care providers, I think our hands are really tied. And that's started way back in how we're trained. When people go through school, they're trained to think in these silos. They're trained to learn treatments and specialize within these silos. And so we come out thinking that way, and we lose the ability to look at the patient as a whole and really think, how is their diabetes affecting their behavior? I loved the example where you could literally connect the two. What was going on with housing, I think, with their substance use. And I think that's a big shift we have to make in our education and then our supervision. And I will say, at least as a clinical psychologist, and from what I know, most states in social work and marriage and family therapy, the licensing also doesn't require any of this. So you can go all the way through school, you can be licensed. I think we're doing so much better having access, especially with COVID. It's forced us to put a lot of things online. The problem is access is really only a small piece of the pie if what you're getting is either not evidence-based care, or I can only treat sort of this little section of you, and then I have to refer you to 3 or 4 others. And I have to say, David, I loved your child view, because I'm a child psychologist by training, and it is the forgotten age group. And I think that it's that also is a really big divide that happens in our education, in our supervision, all of our postdocs and fellows. It's either child or adult. And what happens in the real world is, if you treat someone's child, the parent's willing to go to you, but they're not great about being referred out, or there's a long list for referral. It's a completely separate agency. And so I think if we start creating policies, and I'm not saying it's not going to be painful, and there's going to be challenges along the way. I think that it's not an easy process, but to start changing that conceptualization, and then really encouraging funders and our licensing boards to try to think about things in a different way as best we can. I think that's the only way we're really going to get to integrated care.
Yeah, thanks for the shout out. But I do think that I'd add to what you just said, that training matters, and the way money flows matters. And we went a long way over the last 30 years to really create silos, both within government and within the commercial insurance system, that have bucketed these types of care in different ways. And the more we can, and then for children, there's the additional silos of a separate education system, the separate social service system that all overlaps with this. How do you braid these things together so that you can create combined services? And there've been some really interesting pilots that have tried to do this around the country, that have been quite successful in their small scales. I think the challenge is, how do you take that to scale at a countywide or a statewide or a national level, is one of those things that we're just going to have to wrestle with. We split up the Department of Health, Education, and Welfare 20 years ago. And to me, that was one of the greatest mistakes we ever made, because for kids, health, education, and welfare are all the same thing. They just have to be combined.
Yeah, I characterize the work that I do as being a silo buster, and the silos are maddening because they're so entrenched in our system that it's really hard to overcome them. You know, both in terms of funding, flow of funding, in terms of attitudes. People kind of get entrenched in their narrow scope, and then fail, and we don't have good connectors to try to pull those systems together. I think I agree completely with both of you on that breaking those down and trying to overcome some of those barriers there is probably a key part of the work. Suzanne?
I would say that where money goes is important. So we are always advocating for ways to improve coordination of care and outreach and community support. I also think that silos have caused stigma to continue and for lack of parity to continue, and that's extremely frustrating and detrimental to the overall health of folks. And I also think that when we're caring for patients, they feel that as well. And so sometimes they may really have an issue in the areas of substance use or the areas of mental health or the areas of social determinants, but the message has come to them too, that's not really health. So, you know, I know I'm coming to get health care for my diabetes. And so these barriers where money goes, where information flow goes, and where stigma is, also translates to patients. And so I think if you listen to patient language, sometimes they'll apologize for asking for care around issues of mental health, substance use, and social determinants. And when that stops happening, then we know we're getting somewhere as providers and patients together to say, we really do understand that for overall throughout life, health is about those things being married. And I think that's where I look at policy changes. Just someone mentioned earlier today, you know, how differently we treat people who have substance use issues. That's a real barometer to me.
Yep. Stacey?
Well, so we have the advantage in Kaiser Permanente of being a capitated system. which is great. I think it encourages integration to an extent, but I actually think that those attitudinal barriers and the disciplinary foci that you were talking about earlier are really stronger in terms of keeping those silos in place, because even though we're an integrated system and theoretically we have carved in addiction medicine and carved in psychiatry, we still have those barriers amongst the different clinicians. And so, people in mental health, and let me just say, I do see it changing. I've been in the system for 20 years. It's changed a lot, but people in mental health who say, I can't really treat this person because until they get their alcohol use under control, or people in chemical dependency saying, this person is dual diagnosis and I can't really deal with them, and certainly in medicine. So I really think that those attitudinal things are stronger. That's the stigma that exists, keeps us siloed. So.
Good, thank you. Well, thanks to the panelists for your responses. I see Colleen popping up on the screen, and also see that we're right on time to move to questions and from the audience. So, Colleen, what do you have for us?
Great. Thank you, Perry, and thank you to the panelists for a very stimulating discussion so far. So let's keep it going. And I'll say to the participants out there, I have a relatively manageable volume of questions. So if you have a question and you put it in the Q&A, you're likely to, at least at this point, get your question answered. So bring them on. The first question goes to Suzanne Snyder and asks Suzanne whether you can speak more about implementing experts in an FQHC setting. So in particular, this question asks about the selection process for folks designated to be one of those delivering the intervention itself. Can you speak to that a bit more?
So this has been a learning process for us as well. And we actually are right now in a wonderful pilot that's sponsored by SAMHSA to address this. So after our initial launch of universal depression, one of the things that we found troubling was that we still were having a low positivity rate. And remember, I talked about time and timing for our providers. And so we had also had in Illinois for a long time an SBIRT 2 project, which was a fee-for-service kind of project where you could have community health specialists or community health workers or MAs or social workers doing the brief intervention. And so we decided that we wanted to go back to that model, and we're in a testing phase with that right now, where we have 6 of our sites where we're piloting. So what that means is when the MA does the first, the screening, and if it's positive, our primary care provider has a choice. So they can decide that they want to go ahead and do the brief intervention themselves in the screening, or they can say, I would like to have the community health specialist do that. And or sometimes it depends on the workflow, but that it can be either or. And then we have a standard note that is done when it's the CHS, and so then the provider can review that, and so it's answering some of the questions that come about, which is standardizing what's happening, what is a brief intervention, because you want to have fidelity to that intervention. And it also is answering that time and timing question for the providers. So early results are that's very encouraging. And then I think with the funding piece, one of the things that we're looking at is how do we begin to embed those CHSs and be able to have return on investment for that? And so we're really moving towards our community health specialists that do SBIRT, also cross-training with our community health specialists that support our MAT treatment, so that we really broaden across the spectrum and continuum training for community health specialists around issues of substance use. And looking at that too with a HEDIS measure for folks coming into treatment or needing referral to treatment after a first diagnosis of a substance use disorder, so that AOD IET measure. So those are some ways that, right now we're in a pilot phase to prove that embedding and giving providers choice is working, and standardizing interventions and training. And then I would just say that training is so important when you're launching this. So right now, we actually have an external trainer that's working us, a MINT trainer on motivational interviewing, working throughout the summer, twice a month with our CHSs. So I think sometimes we think about training at and we talk about the hierarchy, too high up the hierarchy. And we need to think, like I said at the beginning, feet on the ground, who really deserves and needs and is encouraged and wants to get the training. And once that starts to happen, you can see changes. So it's important that there's fidelity to interventions, but thinking about who else to train is really important.
Yeah, I'll go. I've been involved with two different waves of SBIRT implementation in Colorado. An earlier one where would work with primary care practices, and they would embrace it. But the big barrier was knowing who to refer to. I mean, they had no, it was such a hodgepodge in terms of who could go where, and also just the overall deficiency in the number of treatment programs really squashed most of our practices from really fully embracing it. Now we're going to a model that includes trying to support the practices themselves and doing MAT to the degree possible, kind of harking back to Richard's presentation earlier. And we'll see how that works. I mean, we're just really getting started, but I think that'll be much more successful because that has been such a barrier to a lot of our work.
Great, thank you. David, I think this next question is maybe to you, although others might chime in as well. Can these elements of care be helpful with a child with mental health issues who's avoiding treatment? So are there elements of these models that can help us in pulling people into care?
So yeah, I think when you're thinking about families that are resistant to treatment, for a number of reasons. It can be that the family's not engaged, the family doesn't see it as a problem, the child is old enough to be able to say no effectively. Sometimes, they can, and sometimes there are different ways that happens. This is one of the places where having an integrated primary care practice is helpful, because a big chunk of what we do in primary care is we walk with our families. I'd submit that the mere act of walking with the family and continuing the conversation allows you to move that person through. It's kind of the Prochaska stages of change model. You've got a pre-contemplator that you're trying to move to contemplation. And we know how to do that in some ways. We have frequent conversations. We know it's going to take time. We know you have to build trust. And that you can bring them along there. We can do that in a primary care setting because we're not bound to the same kind of diagnoses that the mental health system is right now. I may apologize to some of my colleagues, but I get frustrated when a patient doesn't show up twice to a mental health visit and I'm told that they are no longer going to be seen by the center after that. To me, those are the patients that you want to continue, that you have to say, that engagement didn't work. How am I going to engage with these folks? Is it is it a telephone call? Do I have a community health worker I can send out there? Maybe a bag of food would be helpful. Something that lets you build the trust that you need to be able to move them from pre-contemplator to contemplator. And sometimes you have to do that with the parent first and then the child. Those are two separate negotiations, if you will. But it takes time and relationship. And the beauty of primary care is that our fundamental value is relationship, and everything else we do is built off of that. So we're able to do that. I think that's what you have to do. It's long, it takes a long time, it takes time, commitment, and it can often be frustrating. I've certainly had families that I was never able to bring past that change, but that doesn't mean I stopped trying.
That's fantastic.
Can I just jump in? We had a very successful successful adolescent ESPERT trial where, and it wasn't just for alcohol and drug use, but also for depression symptoms and anxiety and stress with teens. And what we found was that just having that warm handoff and an introduction to a really friendly, welcoming behavioral health clinician in pediatric primary care, and maybe some texts or some phone calls in between time, introduced teens to the idea of talking to a counselor, where before that they might have been really afraid to do that, and that just seemed very scary. Therapy, treatment, and meeting somebody who was nice and warm really helped facilitate, and we had much better results of getting kids to initiate treatment than if they were just given a referral and told to call, or their parents were told to call, because so many people fall through the cracks because it's such a fraught, scary thing, talking to a mental health person or a substance use treatment counselor.
Yeah, I think that's a really good point. The other nice thing about being an integrated practice is very often our families have met the psychologists and the social workers that we work with in a non-crisis situation. So we have a program. Oh gosh, I'm forgetting the acronym now, but there's a there's a program basically where they come by some of the well visits and just offer families some behavioral support without saying your child has this problem. It's more of a, we often see this problem, you might want to take this stuff. So for us, bringing in the behavioral specialist is not stigmatizing, because it's not, because they've stopped by before, just when you were bringing in the child for a well visit, and and just sort of said, hey, how's it going, and we just talk about it. So I think being able to build relationships when you're not in crisis is incredibly helpful when you move into the crisis. It breaks down at least one of the walls that you have to get through.
Yeah, I think that every well child or well teen visit should have a physical checkup and an emotional checkup. And it just normalizes that as an important, part of your health care.
Yeah, my wife and I used to say we didn't need a primary care pediatrician, we needed a primary care psychologist for our children. Yeah. So I think that kind of attitude works.
Yeah,
I think that hits on the huge value of integrated sort of systems in the way that we talked about it earlier. When you have a team of people who really are taking care of the patient within the context of the primary care practice, you can kind of get to the point where you're not distinguishing that this person is a substance use counselor or a behavioral health therapist, but they're just part of your team that is taking care of all of their needs. And it just, those sort of warm handoffs from one person to another and joint team-based care planning, depending on what the patient's expressed priorities and needs are, is really at the heart of delivering good primary care. So great, I totally agree with those comments. I'm gonna, go ahead.
Oh, I wanted to share something similar that we do oftentimes in our OB clinics, particularly when we have a new BHC, and if they're not busy and they're not getting enough flow, that they'll go down to the OB area for an afternoon and ask if they can go in behind the provider and do education around perinatal depression and perinatal mood disorder. And what I've learned from this, from myself doing it, is that we have to remember that screening someone does not mean they're being educated. And so sometimes what we've learned from this is that the patient didn't even know what the screening was for. And then when they begin to talk about it, that other things come out, or the willingness, not just one time, but oftentimes RBH will say, they're telling us, oh, my niece had this, or my sister, oh my gosh, my neighbor, they haven't come out of the house for 3 weeks since pregnant, since giving birth. Do you think this is a problem? So it also means you need to then be willing as a health system to say, yes, we're an FQHC, so we say, yes, please come, please bring your neighbor, your sister, your niece in. And we've had those kinds of things. So I would like to say that I think that's another way to use BHCs is if they have time that's free, it normalizes to say, I can educate on why we're screening. I can educate on what you should look out for, and that it's non-threatening, and it begins to be, I share with the patients saying, we play these games when you're expecting by putting it, a needle over a belly to see if it's a boy or a girl or what. How about the next time you talk to your friend who's expecting, ask them, did your provider do a screening for depression for you? So we do an each one teach one also with women in OB, encouraging them to as people that care about their sisters and cousins and whatever to educate, and they actually start to do that, and it normalizes.
Yeah, one other thought. Now I just turned and asked my nurse. It's we've got all of our behavioral health folks trained as Healthy Steps provider, and Healthy Steps is an evidence-based program of essentially preventive behavioral health care for kids. If you can talk your state Medicaid agency into paying for it, then it becomes a billable service and allows them to establish a relationship in that way. And some states do pay for it. I think North Carolina is one of them. There may be some others, but that's another. I think those kinds of vehicles are going to be really important to us.
So I'm going to take there was one question for the panel I didn't get to that I'd like to ask at this point, because this one has been bugging me in some ways. With COVID-19, I mean, we're currently practicing with that specter over us. And I've seen with the practices that I'm working with major impact on how they deliver services. And so some of the models that we're talking about really have had to shift in the face of that. I'd love for any of the panelists to comment on what you're seeing there in terms of how it has impacted behavioral integration in the practices or systems you're working with.
Well, I can certainly talk a little bit about our system. It impacts it in several ways, but the biggest has been the development and rapid implementation of telehealth within our system. And we're actually using it within the clinic. So one of the things we're concerned about, our multidisciplinary team often walks into the room together, and that creates a social distancing problem. We're not maintaining proper conditions for care within our clinic. We now have iPads on wheels, and the behavioral health folks are living on the fourth floor, and when they're coming in to visit, we wheel them in and introduce them, and they're sitting there on a screen, so we're not doing that. That's actually worked remarkably well. Our care navigators still come down in person because they're often bringing bags of groceries for the patients, the families. But it's, how we've integrated with telehealth has been huge. And of course, it's demonstrated the digital divide, which is real. But I'm often surprised at who has access to good internet and who doesn't. It's broken down a few of my stereotypes, I'll just say.
So in our system, we are, we're right in the midst of a surge, and we're still really at video first as our approach to non-emergent care. Which is challenging, but I will say that our clinicians, everyone, medical assistants, behavioral health, providers have all shifted very well to virtual care and televisits or video visits, and actually are finding really like warm handoffs. They've found very seamless ways to do that, and I think it opens up a lot of opportunities for the future moving forward, to having those kinds of maybe even additional types of care happening during child visits, well visits in adult medicine than we have now. So where medical assistants can have a visit ahead of time do screening across the board and then hand off to the physician, or physicians can start a well-child visit and then hand off to a behavioral health clinician. It's already happening. So I actually think it opens up some really interesting opportunities moving forward. I don't think we will ever now go back to, now everyone has had to jump into the deep end of the pool in terms of virtual care. I don't think we'll ever go back to fully in person.
Yeah, the fascinating thing is going to be how some of these models evolve for doing all of this in a virtual world. It disrupts some of the relational aspects of what we do, and certainly not for every patient in every situation, but I'm seeing some really interesting solutions emerging. And I'm particularly seeing the behavioral health clinicians within primary care practices really rising to the challenge and doing some great care in the midst of obviously a lot of stresses for our patients. So.
Well, I think there are some, I was just going to say, some economies of scale that we can take advantage of, so that not every clinic can afford to have somebody who speaks Vietnamese or speaks, you know, Cantonese. But if you, at least in a system like ours, you could centralize some of those so that someone could easily be handed off to somebody who is culturally and linguistically, you know, a good match. So I think there's some interesting possibilities.
I think one of the, if we can say one of the positive things that have come out of COVID is I do feel like it has pushed our field to move quicker than we probably were in talking about better access and some of those things you were just mentioning, Stacy. I will say that, you know, we've talked a lot about what do we need to do policy-wise to change some things. And I think policy-wise, one of the things we know we need to do in the mental health field is make sure people have access to evidence-based training. Many don't. And David, you mentioned like there's an evidence-based programming, but you have to find funding for it or your organization or state. And so most people are graduating without that information. And I do think what we're seeing now with COVID is more people putting their evidence-based training online, which makes it much more accessible. People don't have to travel. And so I would hope that one of the big shifts with this is that our training can become more accessible to professionals, so that they do have the evidence-based care. And they, for example, know how to do, you know, weekly monitoring, as the first panel pointed out.
Yeah, Perry, I just wanted to point out one of the groups of patients that we've actually found really likes virtual care is our kids on the autistic spectrum. For many of them, being able to, the trauma of coming to clinic is actually actually outweighs the benefit, and we've been able to do some really good work with some of those kids through video that I think we wouldn't have accomplished otherwise. That was kind of an interesting observation.
So we have 5 minutes left, and I have a couple more questions. So I'd like to try to get as many of them in as possible. So the next question, I'll leave it to Perry as moderator to figure out who to kick it to, is what are the successful, and this sort of picks up where Laura left off, what are the successful sort of funding or financing strategies that you've seen in the settings in which you're working that can be helpful to rip down these silos, to de-silo, as Laura had put it? So focus on funding.
David, I know you've thought a lot about this. Let me address it to you first, but anyone can jump in on this one, certainly.
Well, if I can shout out my old friends in Massachusetts, I was fortunate to work on the development of something called the Children's Behavioral Health Initiative in Massachusetts, where we were able to braid funding from a variety of sources to fund through the state Medicaid system mostly, but also through the mental health system, a statewide system for wraparound services for kids with who are socially emotionally disturbed, meeting that criterion. But along with it came universal screening and a tremendous uptick in the use of services before that. We actually were able to demonstrate a decrease in kids in crisis going to the emergency rooms and so forth. And I think that that's the kind of initiative that crosses at least within state government, crosses departments that can be very, very successful. And you can talk to them about it. It's now 10 years old. It's pretty mature. But we saw a really rapid change between like 2008 and 2012 when we studied the impact of that kind of a system. I wish I could say Colorado was as successful. We're still trying to develop systems like that out here, but haven't moved as far in that direction as we should.
Other comments? I will say that the thing that ends up being particularly maddening is just in a state like Colorado, where we have multiple different payers and no single large-scale health plan that has the majority of the people enrolled, trying to navigate this across Medicare, Medicaid, and multiple different payers is crazy making. And so you'll get movement in one area that will start you down a path, but unless you get everyone engaged on and really paying in a different way, it's hard to make progress. So the analogy is often, as you're trying to get out on a canoe and you have one foot on the dock and one foot in a kind of shaky boat. That's where we leave a lot of our practices. And I see that not just in Colorado, but across the country. I think it's going to take a major move. All these iterative sort of steps only work so far, and there's a point where you have to make a major move toward an all-payer sort of system, whatever that looks like, with a lot of the things we've talked about in some of the other presentations. So without that, it's very difficult to get there. Colleen, you have another one?
Oh, so could the panel speak to the need or opportunity, or I guess, let me phrase it differently. Could the panel speak to opportunities for integrating behavioral health and medical care, specifically in corrections settings?
Well, other folks are thinking about it. I'm actually involved with a project right now that's kind of fledgling, but trying to work with jails across Colorado in terms of their screening and treatment for mental and behavioral health issues, substance use, et cetera. Unfortunately, I think COVID-19, and we're learning a lot. I think jails are, as you look across the state, a lot of these systems are very hungry for help in this area. And it gets you into kind of breaking down some of the silos we've talked about. I mean, there are all sorts of levels of social needs as well as behavioral health needs, as well as kind of integrating with the primary care and behavioral health workforce. A lot of integration and silo busting that needs to occur on that level. We're just getting a taste of it, and COVID-19 may end up kind of at least temporarily cutting our funding for that, what was going to be a multi-year program. But I'm real interested in if anyone else has any experiences in that area. I think it's an incredibly ripe area.
So one of our successes is working with other agencies that work in the discharge area at Cook County Jail. So I'm sure Cook County Jail's reputation precedes it. But our folks that come out of Cook County Jail come out 24 hours a day, 7 days a week, usually with no foreknowledge of what time that discharge is going to happen. And so we do have people in a discharge area at the jail that are able to schedule appointments for folks, specifically if they're coming out of the mental health hospital, which is one of the biggest mental health providers in our state, is the mental health hospital at Cook County Jail. And so we and other FQHCs have a system where people can get registered next day into our health centers to get a visit. And this becomes really critical for patients going into IOPs or other substance use programs, because the first thing that substance use program needs is that there is a clearance, for a medical clearance, and sometimes medications being gotten so that they are not prevented from going into substance use care. So this is an area we're working on. And then we also work with a lot of our safety departments, and also not in Chicago yet because it's such a big system, but in some of our collar suburban areas. So working with court diversion for MAT care, and then partnering with some of our larger agencies around social determinant issues for folks in MAT or who have chronic mental illness, and also, you know, high needs for physical care around housing, because it's so hard that so many of the housing programs, they just are precluded from getting housing. So to tackle that, you know, we've learned we really have to work with the agencies that are really in a big way working on that when we're looking about a system as large as Chicago. But those are 3 areas where we've had some success.
Colleen, I see we're about to run out of time. Do we need to transition or do we have time for one more?
I don't think we have time for one more. I think we need to transition, but on behalf of all of the Planning Committee and Howard as well, I want to thank Perry for moderating a fascinating session. David, Stacy, Suzanne, and Laura, thank you all. And I'm going to kick it back over to Deirdre and to Ruth, our fearless co-chairs for the Planning Committee to close out our session. Ruth and Deirdre?
Well, thank you, Colleen, and thank you, Perry, for facilitating a very stimulating discussion. Again, I'd like to thank all of our distinguished panelists, Drs. Richard Sates, Sarah Wakeman, Lydia Schwastiak, Frank Degree, David Keller, Stacy Sterling, Suzanne Snyder, and Laura Murray for their very thought-provoking and boundary-stretching presentations. Session moderator W. Perry Dickinson, Forum chairs Drs. Colleen Berry and Howard Goldman, co-chair of our webinar planning committee, Dr. Ruth Shim, and all members of the planning committee, the National Academies of Sciences staff leads Laureen Gray, Caitlin Friedman, Anicia Wilkes, Cheryl Nass, and the entire team at NAS, and a special thanks to our audience for joining us today. We'd like to remind you that today's webinar was recorded and will be archived on the NAS website. And we sincerely hope that you'll join us again for the 3rd and final webinar in this series coming up on August 26, 2020. Links to register for this webinar are also available on the NAS webpage. Although a virtual event such as this could never replace a face-to-face experience, we still feel a strong sense of connection to everyone who participated in today's webinar. And we hope that you too found it to be empowering and rewarding. In light of mounting evidence of rapidly escalating rates of anxiety, depression, and substance use, conversations such as these are more critically important than ever, as they are shaping the values, policies, and ensuing actions that will determine how we emerge from today's converging public health crises. Your partnership and willingness to engage in transformative dialogue reassure us that one day in the foreseeable future, the design of US healthcare systems will consistently reflect the reality that optimal physical health is only possible where there is optimal mental health and vice versa. We thank you for the inspiration, and as always, we wish you continued safety, vibrant health, and peace. Ruth, would you like to say something?
No, I think you said it all, Deirdre, and I just want to thank you all for coming, and we'll see you in a month.
Thanks, everyone.
Bye.
Bye.